Can do countdown.
Live now, ma'am.
Good evening, seniors, ladies and gentlemen. Welcome to PPH Skill and Drill, organized under aegis of societies of Bhagalpur, Bokaro, Dhanbad, Jamshedpur, and Ranchi. PPH is the leading cause of maternal morbidity and mortality. The preparedness to face obstetric challenges through regular drills and protocol-based approach is the key to face and handle obstetric emergencies. So let us start the webinar with lamp lighting. The chief organizer today is Dr. Sadhna Gupta. She is the co-chair, Suffolk NCD committee and Foxy representative to Suffolk. Madam, I welcome you and request you to welcome our revered guests, Dr. Rangila Sinha, Madam, Dr. Alok Kumar Devdas, sir, and our guest of honor, Dr. Usha Nath, Madam.
Thank you, Moshmi, and very good evening to all, and my pranam to our teachers of teachers, Dr. Rangila Sinha, Dr. A.K. Devdas, and Dr. Usha Nath, who have been like in my journey of 30 years in Foxy. It has been the great, and I've been blessed to have their blessings, guidance, inspiration for all the things what we have done in the publication, in the workshop, project Pan India, and doing a lot for the saving mothers, which is our passion and profession. So this is a continued series of e-classic for clinician, and we have kept the focused subject for this series, cesarean section, adolescent gynecology, and postpartum hemorrhage is the thing for which we are passionate, because it is still one of the major contributors to maternal criticality and mortality. So thank you very much for the Ranchi, Jamshedpur, Bokaro, Dhanbad and Bhagalpur Society for always being together and all the coordination, so that on this Sunday evening when we are having monsoon showers all over the world, we are together for our mission for joining hands, head and brains for saving mothers. So hearty gratitude and a warm welcome to all office bearers, revered guest, President Secretary of Ranchi, Jamshedpur, Bokaro, Dhanbad and Bhagalpur Society. We have been a close association with all these societies. I have visited almost every society in last 4 or 6 months and many times in last 30 years. So it is a strengthening relationship, reconnecting, rejoining, relearning and sharing from everybody. With this, it is a great pleasure to have the teachers of teachers, Professor Rangila Sinha and Dr. A.K. Devdas as revered guests. And can I have a CV? Because they are known to everyone. Generations of students and the people who follow them are there in the field of obstetric and gynecology. Dr. Rangila Sinha ma'am has been the professor and head obstetric gynecology, SK Medical College, Muzaffarpur, vice president of Foxy in 1992. Chairperson, Public Awareness Committee of Foxy, founder president, Muzaffar OB-GYN Society, and the founder president of Association of Obs-GYN Society of Bihar and Jharkhand. 99, and we have just have been to Bhagalpur for a wonderful Society, the annual conference of the Obstetric Gynae Society of Bihar and Jharkhand. So what Madam has said, that is a legacy actually what we have, and we have to carry forward. Sahiti, please share the CV. I have not done yet. Yes. So has presented many papers. She is a known faculty. Area of interest is gynecological ultrasound, safe motherhood, and eclampsia. And what is written her autography, and I have been blessed to have the copy of this book, A Gynecologist Born in Adversity, My Life Story. So ma'am has been the inspiration that no difficulty can actually prevent us for doing our best and for committing to our aims and mission. So Dr. Rangila Sinha, we wish to hear from you. And everybody wants to listen to your pulse of wisdom. Ma'am, unmute कर दीजिएगा. मैम
रंगीला मैम आप म्यूटेड हैं. मैम अनम्यूट करिए. रंगीला मैम अनम्यूट करिए अपने आप को.
हाँ. Now it is okay?
Yes, ma'am.
Yes, madam.
Dr. Sadhana, अब हुआ है. Yes. Thank you very much, Dr. Sadhana. And so all doctors from Jamshedpur, you know, I wrote my book that was inaugurated in Jamshedpur in 2017. So I have got very much soft corner and very good memory of Jamshedpur Obstetric Gynae Society. And I have actually joined as guest in so many conferences Dr. Sadhana Gupta has organized, and she is regularly sending important subjects, and I have collected all. At present, I have not read so many, but it is very good. I think that it is a very, that is academic wealth. Actually, it is academic wealth for us that you have written so nicely. And being a brilliant gynecologist, as I have seen just now, and I was knowing, you are not only brilliant, but you are so hardworking. Whenever I attend her any meeting or when I see her, I always remember a very simple girl with a small hair and salwar kurta, all the time working, all the time discussing some important activity of Foxy with different teachers, senior persons. So that picture is always with me. Whenever I hear about Dr. Sadhana, I immediately remember that how hardworking she was. And I think that I bless you. I wish that you can you should get opportunity to serve Foxy as you have served for so many years, and we need this type of academic and hardworking people in Foxy. So far this PPH is concerned, PPH is the most common cause of maternal mortality. But I remember 20 years back when I was very active in this maternal mortality, then eclampsia and pregnancy-induced hypertension was more common. And at that time, Professor Ratnam, he used to come, he came in Muzaffarpur and he inaugurated AOG, that AOGS workshop, AOFOG workshop there, in which all strata of people came, teacher, public health, public representative, then ANM, and that was his idea that this maternal mortality started falling, and now I was actually very much impressed when I saw that it was 2015 or less than 15 years back, when maternal mortality was so high in referral tertiary center in our medical college, it was 440. Once I calculated, then I was 440 per 100,000. And now I have seen that it is only 70. So in such a small time, this maternal mortality has dropped, and it is all due to the hard working Foxians like you. And I hope that it will further maternal mortality and will further go down with people coming in this association like you. So I wish you all the best, and I wish that at 85 years I am still active, and you should be also as active, as more active than what I am, because there will be more improvement, more research on healthcare. But you must give some time. Give time to your profession, your academic activity, but I will advise you that must give some time to yourself, because until you yourself be healthy and active, you can't help any other your relation, your family, your nation, your profession. So that is my message for today. Blessings.
Thank you, ma'am. Thank you for your the word, like memorizing my word and my appearance. And thank you, ma'am, for your precious blessings for my upcoming election. And thank you that your care, your concern that for my health and well-being, because it is what matters in life, that really the elder persons and the teachers have take care of you. So that is a great thing, and we look forward always to Madam Dr. Rangila Sinha for inspiration. And I've seen how passionate she is. Madam is so updated, have a keen watch on every activity of the all society working. And I has been blessed to visit her home and made like a brilliant daughters who are the OB-GYN, and you are all inspiration for all ages. So thank you, ma'am, for everything and for your precious time. And Dr. A.K. Devdas, another legendary figure who I have been like found as a father figure always in Foxy. Dr. A.K. Devdas has been Vice President Foxy 2006, President ISOPAP 2004-6, Chairman Indian College of OB-GYN 2012, peer reviewer of many journals, Korean awardee, and a brilliant, I think what Dr. Devdas have authored, we don't have any parallel book in the world, that is the drugs in OB and gynae. And he has a real innovative mind, innovative technical mind, like paperless partogram, growth tape, descentometer, and always a person who has a very like wise person. And his appreciation means a lot, because sir has been like something who does every work with a lot of concentration. And what is not written is that the Dr. Alok Devdas is very much in the literature also. So he is a something known figure in the literary world, especially in Jamshedpur, a very sought after. So multifaceted personality sir is, and always a source of great inspiration across the generation. So we'll look forward to listen from you, Dr. Devdas.
Devdas, sir.
Am I audible?
Yes, sir.
Yes, sir.
Please.
Dear Sadhna, my congratulations in advance. I think looking at the scenario, you look to be uncontested for the post, because there is no one parallel to you competing for this great service to Foxy or women at large of India. And I have known you, I don't know, 30 years or something. Always extremely active and dedicated. What else to say? We have met in various conferences here, and the subject that you're going to talk about, PPH, has been also my concern for many, many years. And you have propagated it in all over India, even in World Congress. You presented some 3 years ago in the central platform, the PPH bag, etc. So I'm hoping, by another few months, you will see your name flashing all over India. God bless you. Carry on the good work. Of course, so many books that you have written must be appreciated. Well, thank you. God bless
Thank you, sir. Thank you, sir, for your precious word and for your gracious presence. And we recognize very, very senior teachers. Dr. Preeti Bala Sahai, madam is looking so smart.
Thank you, Sadhna.
And
Sadhna, 2 days back, I have been operated cataract surgery.
Okay, ma'am. But it is looking, yes. I wish you all the good recovery. And very, very close friends, Suman, Kavita, Nivedita, and Minakshi, Dr. Roma, Dr. Leena Nair, Dr. Sumita, Dr. Purva, and then Ranni, Shashi, who has been always with us in our mission. And we are taking a lot of time. And of course, Moshmi for all the coordination. So thank you always. It is a gratitude which is actually that matters, that having the company of such a seasoned and such a nice person. Dr. Anu is with us. So is there something blessings when we work selflessly for any organization. So thank you. And Dr. Ushanath is with us, teachers of teachers. So yes. So Dr. Ushanath, madam is again a person who is always having a keen eye on everything, be it in Ranchi society, be it all over, and she reads meticulously everything and gives her comment on every talk and every subject what she gets, and that speaks a volume about her. So Dr. Ushanath has been the medical director, chief consultant, OB-GYN, Nath Hospital, Ranchi, senior colposcopics, women cancer prevention colposcopy center, and past president of Ranchi OB-GYN Society, and patron ROGS, and have authored a book of rules and regulation for her society. So her work and interest, cancer cervix, and her long contemporary for MRCOG book, open first colposcopy services in UAE, and the free colposcopic examination for needy women in women healthcare camp. So actually, when we see today so many changes and so many availability and accessibility of the thing, we had to recognize that when this technology was not available, not used, how the senior people and teachers actually took the baton to spread this awareness and utilization of this technology. So madam has contributed a lot of chapters, and she has been instrumental in many conferences what is being held into the Ranchi, and she has the good research paper, relationship of cesarean section in relation to maternal well-being, colposcopy with BIA, and the comparison of incidence of cervical dysplasia in urban and rural population. So a lot of field studies. Thank you, ma'am, for being with us, and we wish looking forward to listen from you. Dr. Ushanath, ma'am. Dr. Ushanath, ma'am.
Madam was there, but now I can't find her.
Usha madam, Ushanath madam.
Madam is here only. You can see, but she is joined, logged in.
Hello, can you hear me?
Yes, madam, we can hear you.
Okay. but I don't know why I'm not getting my video. This,
Madam, we are able to hear you.
okay, so that's okay. You have seen me before, so as long as you can hear me, that's great. So, thank you very much, Dr. Sadhna, for your kind words. And I have always been very impressed by you and have felt very emotional and affection for you. So actually, I can say that when I met you, when I was a president in 2013, and I wanted to start a oration and paper for our own Ranchi Obstetric Gynae Society creation. I discussed this with Dr. Alok and came to realize that Dr. Shobha Chakrabarti is the one who is so loved that everybody will love anything about her. Usually we keep the oration after the person is not in this world. But I felt that if we do something like this, Shobha will be very, very happy and appreciate this, her appreciation. So at that time, that was the first CME which I started, and I was thinking whom to call, and decided Dr. Sadhna Gupta, and I gave her one phone call and she agreed. I was amazed that she didn't know then me, and still she just happily, willingly, she said yes, and she came. And I have also appreciated her work as a safe motherhood committee chairperson, and she sent me so many bullet journals, and I have seen all of them and I started to read them, and I really felt very impressed about it. And I really am very happy to be the guest of honor of this highly acclaimed topics CME, and feel really honored about it. About PPH, Dr. Rangila Sinha has said everything overview about it. I just have to say that PPH is an age-old happenings. And we have been discussing about it even when I was a student, when I was working in UK and all this, that this has been a very hot topic to save mother and also from her morbidity, because it leaves a long influence over her life. So we have been discussing how to curtail and control this unwelcome event. But I have a question to all of you. Will we be able to prevent this at all with all our mights and newer tools? I feel not. Till the earth is habitat with mankind, the childbirth is an important part of it. And the PPH will keep visiting us unexpectedly with all our efforts. However, we have been successful in reducing this event and have reduced the maternal mortality to some extent. So, with Manyata and with Street and other development toolkit and training and nurses training, we have done this. But I'm waiting to listen to Dr. Sadhna and other to see what newer things have happened. And also I'm welcoming all involved in this, and I'm thankful to organizers. Thank you very much.
Yes, Sadhna ma'am.
Yes, yes. Actually, I'm changing my places of this thing. So thank you, ma'am. And for your precious words. And I'm really privileged to have delivered Dr. Shobha Chakravarti inspirational paper twice at Ranchi. And that is a great association. And now Ranchi society has all society, what we can say, the Ranchi, Bhagalpur, Dhanbad, Bokaro, every society is bringing up the leadership, potential leadership, and we are creating wave. Be it Sumanji, be it Kavita, be it Apurva and Nivedita, and this is the thing actually what we wish to see into the future Foxy, that we must have the expertise, experience of all over the country, and it is something as a presidential candidate, my commitment that we will make the Foxy phase the all-inclusive. It will have the balanced representation. It will include all teachers. This is my commitment. We have a teachers like Madam Sinha, Dr. A.K. Devdas, Dr. Usha, Dr. Preeti Balasai, or so many teachers. And the teachers must have a respectable place in Foxy for our thought process, for our program implementation plans, irrespective of any electoral issue. This is the thing, because when we honor our teachers, then we are really capable of bringing like the best minds to the obstetrics and gynecology, because their guidance is with us and they are framing the future generation. So many things we have the plan, and it is a great thing. I think you, Nivedita, Suman, Kavita, Anu, Arup, everybody I have been very, very encouraging for people, and never lose heart and go on, and that should be the way. And come emphatically, go on improving yourself. And Moshmi, which is doing excellent, she is with coordination and that thing, despite all the things. So it is a great thing, and which we really look forward. And I again seek blessings of all seniors and teachers, that we can really make a change and our society a force to reckon with. So Moshmi, you can go ahead. I'm really sorry for this light and this thing, because in Jamnagar, the hotel light, I'm keep on changing the place, but now I will stick to this.
Ma'am, can we have a video of yours to all the societies of Jharkhand?
Yes. That will be a great pleasure.
चल रही यूं ही चल रही कितनी हसीन है ये दुनिया फूल सारे झमेले देख फूलों के मेले बड़ी रंगीन है ये दुनिया रुम दुम दाना रद दुम दाना रुम दुम दाना रद दुम दाना रुम दुम दाना रद दुम दाना भैया रास्ता है कह रहा अब मुझसे मिलने को है कोई कहीं अब तुझसे ये रास्ता है कह रहा अब मुझसे मिलने को है कोई कहीं अब तुझसे दिल को है क्यों ये बेताबी किससे मुलाकात होनी है जिसका कब से अरमा था शायद वही बात होनी है यूं ही चला चल रही यूं ही चला चल रही जीवन गाड़ी है समय पहिया आंसू की नदियां भी हैं खुशियों की बगियां भी हैं रास्ता सब तेरा तक है भैया यूं ही चला चल रहा है, यूं ही चला चल रहा है, कितनी हसीन है ये दुनिया।
Thank you, Mojmi. It was simply lovely and nostalgic. And what Dr. Uchana say, I was always in something very simple dress and something it was nostalgic. Thank you, Mojmi. And
The
a
picture
wonderful.
started from 2015 when you first visited Jamshedpur as vice president.
Yes, and a wonderful melodious song that is really, really inspiring. Thank you, Mojmi. That is something.
Shall we
all
now
love and
begin
affection.
with the first
Yes.
session?
Yes.
Yes, for the first session, the keynote address, the speaker is Dr. Sadhna Gupta, madam, and we have chairpersons, Dr. Preeti Bala Sahai and Dr. Mamta Datta. Dr. Preeti Bala Sahai, madam, she has passed MBBS in 1971 and MS in 1980. She was the ex-professor and HOD, Department of Obs and Gynae, Rajendra Institute of Medical Sciences, RIMS, and also external examiner of postgraduate, undergraduate, and DNB students, expertise in oncology and pelvic surgery. She has several publications and several honors and distinctions, like ex-chief coordinator, EMOC, RIMS, past president of Ranchi Obs and Gynae Society in 2007 to 2009. Welcome, madam. We have Dr. Mamta Datta. She is also the past president of Jamshedpur Obs and Gynae Society. She is the chief consultant and HOD, Tata Main Hospital, Jamshedpur, and chief medical support services, Tata Main Hospital. May I request Dr. Preeti Bala Sahai, madam, to introduce our speaker and start the session. Yes, madam, please.
There is a mute. Thank you, Mosmi, for your kind words and nice introduction. Very good evening to all and welcome all of you in this webinar and this keynotes on PPH, resuscitation and mental management of PPH. The speaker is none other than Sadhna Gupta, because you know why I am wearing the glass. 2 days back, my cataract surgery has done. So everybody can read this, but I can't. I'm giving the introduction, the personal introduction of Dr. Sadhna Gupta. It's my pleasure to have a chairperson, Dr. Sadhna Gupta, in this your Jamshedpur Society. Just a few weeks back, she was in Ranchi. I was the chairperson, and the speaker was Dr. Sadhna Gupta. The talk was medical management of fibroid. So I'm very happy. It's my pleasure to have a chair. Again, Sadhna Gupta. Personally, I can give you few words or the few introduction of Dr. Sadhna Gupta. I know her since 10 years when I was HOD in RIMS. She has she is main author of the textbook of Obs and Gynae. So very nice books. So I have asked to the MBBS assistant, even the postgraduate assistant. So please buy it and read it. It's a very nice book. She's a main author and so many publications, so many. Personally, she's a very nice lady, kind heart, always smiling on her face, and very hard work, as the Madam Rangila Sinha has said. And everybody, I think she was the vice president that I know, and every time she visited Ranchi, we are very happy to receive the Sadhna Gupta. Now she is. This is the few words of the introduction personally, because I can't read it by eye.
It's okay, ma'am. It's okay. It's okay.
No problem. No
Yes,
problem,
yes,
Sadhna.
yes, because you are having it's okay.
Yeah.
I'm very much like a part of all societies, and so I, with the permission of chair, Madam Preeti Bala Sahai and Dr. Mamta, I can start my presentation.
She is going to speak on PPH, the resuscitation and its medical management. The resuscitation is very, very important. It depends upon the patient, upon how much the blood loss, amount of the blood loss, and how you will do. Number one, everybody knows the main cause of maternal mortality, PPH, as Rangiladi has said, everything about the PPH. But one thing just I want to add and said, the diagnosis is a very, very important and prompt referral from the PSC level or the rural hospital to the center, higher center or medical college. And to find out the resuscitation, that oxygens, or just patient came in the labor room or any emergency room, just to keep your hand on abdomen and palpate, whether it is a tonic PPH or something else. So the medical management has very last 40 years back when we were the resident or something else, the argometrin and oxytocin. So my teacher was saying the oxytocin is a Ganga Jal. This is a Ganga Jal. But now we are not using the argometrin, and newer oxytocin has come. It is for the prophylactic as well as the therapeutic. So, and medical management that you are going to tell us what is the new things, and the audience and the junior doctors and practicing doctors, they must have benefited from your speech and the lecture on the medical management. How you will go into resuscitate that. Dr. Sadhana, the dash is yours.
Thank you, ma'am, for your gracious presence and your all words, kind words. And this is all a big thank for staying together. And it is a great to have the persons like everyone. So it is, we all are from the a land of Buddha, land of Tata, and the actually who have worked, set the example. And they all say what was the common, that they were the peaceful in their core of heart, so that they can give so much things to the world. So whenever we deal with the postpartum hemorrhage, that peace at inner core of our heart and mind is very, very important. So we know it is a statistics, PPH contributing to around 35% of all maternal death, can be up to 60% in the developing world and Africa and Asia. That is something which should prick our consciousness, that Africa and Asia constituting major proportion of maternal death. As a clinician, we are going to have the postpartum hemorrhage in around 2 to 10% of all deliveries. And this is very important. Yes, we want to prevent all preventable mortality as well as the criticality, but the people must also be aware. Like 20 years ago, people were more aware that the life-threatening complication can happen in delivery. Today, especially the educated people, they are not aware of any potential complications. So this is thing that we have to communicate to people as well, so that we can have their cooperation and understanding at time of crisis. Without aggressive management, we can lose the patient in very short span. It can have a lifetime scar, severe anemia, infertility, social abandonment, and all the management issue like hysterectomy, ICU admission, massive blood transfusion are in category of the severe acute maternal morbidity. And PPH related mortality is a lifetime scar for obstetrician and their team too. So when India is coming to the third largest economy, actually, it is a sad fact that the PPH is contributing to around 35 to 56% of the maternal death. We can have a lot of cause. Important thing for us is that what we are doing day in and day out for our nursing staff, for our all the labor room equipments, labor room readiness, availability of drugs. So more you sweat in peace, less you bled in the war. And it tests PPH once you occur, you encounter suddenly, it tests your personality, your leadership, your coordination, your experience, your cause analysis. And that is the thing that we have to be ready. In India, we have all the thing issue like a age-old problem. We are still having every third pregnant woman is anemic as per NFHS 5 data. We have all the issue is still not that bad, but we have still the lack of sound referral system, and the birth child preparedness is still lacking in our population. And we have all the new challenges, IVF pregnancies, pregnant women entering into the late age, they are having obesity, medical core disorder, and they are on the drug like they can cause coagulopathy as well as any obstetrical complication which can cause coagulopathy. So what with this E-Classic for Clinician webinar as well as the physical workshop, we want to achieve, that is the prevention of life-threatening PPH, and we wish to have a clear roadmap in every clinician that when they encounter, they are being called for tackling the case of PPH, how smart is their cause analysis, so they choose the right method for the stopping of the bleeding. If we have the suboptimal, this is the thing that we cannot be the half-hearted. We have to be full-hearted, we have to be aggressive, because if we do the suboptimal management, it will threaten the well-being of mother, family, obstetrician, a big medical, legal, media, social issue, and we have to be ready with this. So government is doing a lot of things nowadays. We are having good road, good ambulance system, and this is our responsibility as a leader, as a obstetrician, as a part of administrative work, that there should be no delay when the patient of the PPH reaches to us. So a few lines about the prevention of PPH, because the prevention is the way of present and the future medicine. This is the way that we don't want to have the life-threatening complication. We were very much daring few years ago. Now it is a risk factor assessment. So in all antenatal care, you have to be very, very particular that this patient is having any risk for postpartum hemorrhage, especially history of PPH. Many times patient does not come out, placental location, multifetal pregnancy, any pre-existing bleeding disorder, treatment with anticoagulant. We are giving a lot of aspirin and the heparin for many, many reasons, and the preeclampsia. But the turning knowledge into action is very, very important. So once you identify high risk factor, flash a antenatal card, counsel family for PPH risk, counsel that you show this card, and on that side, supply side, our labor room staff must be aware that this patient have this flash sign, and we have to ready with all preventive and the curative measures. Active management of third stage of the labor from 1988 to 2012, we have changed a lot, and I have been the integral part of this change process while doing a pan-India HMS and the maternal, this path oxytocin initiative project, where we advocated first time very, very strongly that oxytocin should be kept into the fridge. Before that, it was just lying on the shelf, and when we needed oxytocin most, it was not effective. Active management of third stage of the labor is like a vaccine for the postpartum hemorrhage. It reduces risk of PPH, reduce severe PPH, decrease need of blood transfusion, decrease risk of anemia, and now with delayed cord clamping, it has advantage for the baby. So oxytocin, so many times when we have this path oxytocin initiative and the HMS like a JPAGO study, we show that so many times the thing was that the people were giving methergine after delivery of placenta, which was actually the fourth stage. So oxytocin 10 unit, either intramuscular or IV, within 1 minute of birth of the baby, is the strongest arm of the active management of third stage of labor. Oxytocin has no any contraindication, and any nursing staff can give very, very confidently oxytocin. Misoprostol can be used as active management. Two things about it, that it is a second choice. It is not that effective as the oxytocin. Secondly, for active management of third stage of labor, it must be given either oral or sublingual, and still it is required, though it is not, does not require cold chain and the cold shell, but we have to be careful about the humidity status. So WHO, FIGO, ICM, everybody says very, very strongly that active management of third stage of the labor should be performed universally in every laboring woman, whatever is the mode of delivery, whatever is the place. And now we have the carbitocin, which is the long-acting oxytocin, which has the stronger affinity to the oxytocin receptor than the original oxytocin. And thirdly, that this is available as a room stable as well as the room labile option. India has contributed a lot in this champion trial, where the India was a major contributor across the zones. And one message I wish to give, the second message, that the carbitocin is a very important and a very good drug of choice for cesarean as well as vaginal delivery as active management of third stage of the labor. And we can really replace oxytocin for this drug. It is not that costly also. while patient is having a lot of anemia, sometimes heart disease, 10 to 15% SDP, hypertensive disorder, the beauty of carbitocin is that it eliminates the requirement for infusion after initial dose. And in all these situations, we don't want the continued infusion, especially with oxytocin, which have an antidiuretic-like action. Important thing, use the correct drug, oxytocin or carbitocin first choice, misoprostol is second choice, PGF2 alpha is the thing, and the ergometrin for the management. Important thing is that these drugs should be available. There must be stored well in a good, like a door of the shelf. Use good drug, and every nursing staff must be knowing that they have to load either oxytocin or carbitocin before delivery, just crowning of the, at the time of crowning of the baby, so that they can give it within 1 minute of the delivery of the baby. So this is very, very important thing. But finally, the more you sweat in peace, the less you bleed in war. So the PPH remains unpredictable. And why do we sometimes lose patient and become critical? Because we are a little bit half-hearted in two things: correction of hypovolemia, which has been caused by blood loss, and delay in the cause analysis and control of bleeding. So actually, with our all workshop, be it a physical, be it a virtual, be it a scientific deliberation, we don't want to burden everybody with a lot of things. Important thing is that what is the cause of bleeding in this particular patient and what measure can be the most effective. So this is the golden hour, the first hour when we give the aggressive resuscitation and a good cause analysis, the maximum chance of saving the mothers from criticality and mortality, and never shift any laboring woman. Sometimes we have a heavy ward before that golden hour has passed, and every nurse and every resident doctor should be aware that what they have to do in golden hour: look for bleeding PV, look for uterus height and tone, pulse, blood pressure, general level of alertness, and the oxygen saturation. And for this, we must have the multi-parameter cardiac monitor in our labor room. So while we are investing a lot on many things, furniture, AC, and this thing, actually, these are the cardiac monitor in the labor room, which can actually have a very good impact on our diagnosis as well as the management in the first golden hour. Primary PPH, secondary PPH, we know, but when you are called, first make a quick 360-degree review. And we are having a good resuscitation initial management, but the cause analysis in the obstetrician mind is very, very important, which is prerogative of leader. So quick review of antenatal issue. Sometimes you might not be knowing what is happening. You have just called for tackling this PPH. What was the antenatal review? Was the placenta delivered for normally or not, or it was difficult? It was a difficult delivery. It was a large size baby. It was instrumental delivery, or she was on the drug, and any precedent obstetrical situation which can cause the coagulopathy. Was there any fibroid? So a very quick analysis is important. It is nothing to cram, but it must be in our hard disk of the thought process, so that we can make a very, very quick analysis. Always look, patient was in aspirin, it was withdrawn or not at 37 weeks, heparin, when it was given, any history of the thrombocytopenia or something. So we have to be thinking also of the multiple cause, because we can have multiple cause, like preeclampsia is the cause for the PPS. We are giving Maxel, we are giving nifedipine, that cause atony. If there is a prematurity and the prompt that infection, atony, use of tocolytic. So we can have multiple cause, and we have to think for that. After this active management of third stage of the labor cause analysis, why we still lose the time in diagnosis, which is so very evident that patient is bleeding, because there is no very quick change in the pulse and blood pressure, because the pregnant woman is hypervolemic and her pulse and the vitals does not deteriorate that fast if she loses certain amount of blood. So Dr. A.K. Devdas is with us, who have designed the Devdas bag. Nalini is going to talk on the Chhattisgarh drip, which we can make rest at the point of care to having the quantitative estimation of blood loss. And this is very important that we can actually use them. And the third, very, very important, when there is a less bleeding outside, but the patient having the unexplained higher level of shock, then the things are usually more serious. And actually, we have to be very, very careful about it, like is there a hematoma or a unrecognized inversion. So if the patient give clear instruction to your junior staff, don't confuse them, don't scold them. If they have soaked their 5 soak pad, if there is a 1 soak big sanitary napkin, the blood on the bed sheet, continuous trickling of the bed sheet, and the patient is confused. She is not looking well. She vomits. She suddenly become breathless. This is the sign that she is in the shock, and we must be very, very careful about it. We must have a blue code. I was just visited Dr. VP Paili's hospital, Rajagiri hospital, and they have the blue code and the red code. Red code for the something cardiac arrest or amniotic fluid embolism, and it was really, really working. So we need multiple pair of hands and brains. So we have to have the blue code alarm so that every smart person is with us. Call anesthetist, your smartest nurse, one obstetrician colleague, smartest ward boys and guys. Ask theater staff don't to put the another case for the OT, because we are having one PPH case which might need something exploration in OT and the blood bank person. After that, amount of the postpartum hemorrhage, which is very important, it is 500, 1000, more than 1000. And this is the thing, the rising pulse, dropping systolic blood pressure, tissue perfusion indicator, urinary output, and capillary refill. So in a quick seconds, we can estimate that actually what is the situation. Shock index is with us. Again, we can use only when we have the multi-parameter cardiac monitor, so that every staff is confident for having that, yes, it is less than 1, then we have the breathing space. If it is more than 1, we have to be very, very aggressive. And the classic teaching for the rule of the 30. Then we have to be ready with our all the things, that drugs should be available, oxygen cylinder along with key. I will say to everybody that with the gauze piece, you put the key, you bind that, you thread that key to the oxygen cylinder, so that the key is lost somewhere, it is there, and we really lose that. Clock is ticking in the PPH, and the airways which should be there, emergency trace for PPH, all chart and all contact number. So these are the basic EMOG. We will just say, just important that even the patient have the mild bleeding, what you say, it is around 500 ml. Many times the patient, these patients always have to be watch for the further. They have to be watched for the further ongoing hemorrhage, because it is a very common situation that the patient was having less bleeding, vitals were okay, everything was okay, but the patient have suddenly the 60 BP or the 40 blood pressure. So this is very important. When there is a more than 1000 ml or the more than like a moderate to massive hemorrhage, then all full protocol of measure, resuscitate, monitor, and arrest the bleeding. And what we say, never scold anyone to call you in the night because you think that the patient was okay. So airway, breathing, circulation, give oxygen irrespective of oxygen saturation, and always the green and the gray cannula. Keep the patient flat, warm, and until blood is available, infuse up to 3.5 liter of warm fluid available. So if it is a blood loss of 1 liter, give 3 liter of the ringer lactate or the crystalloid. If oxytocin has been not been like carbitocin has been given at active management of third stage, then you go straight away for the methyl ergometrin and prostaglandin. Always catheterize and bimanual uterine by this aortic compression, especially when we have the sudden torrential hemorrhage, especially in morbid adherent placenta. We must know how to do it. Keeping the uterus on the left side, straight hand, thumb outside, and that much of pressure that you cannot feel the femoral pulse. So sometimes it gives you the breathing space, though the patient is not in the irreversible shock. Always resuscitate, investigate, monitor, communicate, and record keeping. Sometimes it seems very difficult to have the good communication, but in today's time, that communication is very important. And whenever you have time or assign anybody to do all the record keeping, because actually we don't know after 1 hour what will be the thing you have to shift to OT, or what you have to do, or you have to refer. So this record keeping is very important. And I will say, in all chaos, never lose the sight of your case sheet. Always keep this case sheet under your control in your drawer box, so that whenever you are free or something senior person is free, so that we can have all documentation. It should not be lost out of your sight. When you are putting the second intravenous or the first, both IV9 at the same time, send the blood for the group cross matching, for all the investigation, prothrombin time, fibrinogen, coagulation profile, and the liver function test. So this is the postpartum hemorrhage care bundle. And as a presidential candidate, this is one thing that all bundle care, preterm care bundle, sepsis care bundle, PPH bundle care, we propagate to every level of OB/GYN, house surgeon, clinician, practitioner, that so that we can have a substantial change in maternal morbidity and the mortality. So this is the emotive, which says again, shout for help, crystalloid, 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 2 IV cannula, around 2 to 3 times of the estimated blood loss of the crystalloid, warming, catheterization, and why ringer lactate and normal saline? Because crystalloid rapidly equilibrate into extravascular space, they don't remain into extravascular, so they does not cause pulmonary edema. It effectively improves the tissue perfusion status, while the colloid infusion remains intravascular, and it can cause the pulmonary edema as well as interact with the coagulation test. So this is that around 2 to 3 times, and colloid is just in between. When you have given around 2 liters of crystalloid and there is patient is ongoing bleeding, blood component not available, then colloid up to 1500 ml. Ask always right question. Again, you have to review placenta delivered or not, when the bleeding is start, and if there is any possibility of the past disorder. Catheterization, fundal massage, evacuation of blood clot are a simple thing, but they are important, and we have to know how this thing should be done. And all medical drugs. We are fortunate to have now a multitude of the oxytocin, corbitocin, methylargometrin, misoprostol, prostaglandin F2 alpha. We must know 2 or 3 things. First is exclude the contraindication. Methylargonavin, like the valvular heart disease, severe anemia, severe preeclampsia, hypertension, PGF2 alpha, glaucoma, the asthma, and the oxytocin has absolutely no contraindication. So we have to be careful. And the second thing is they should be available in cold, like in the good cold chain. And thirdly, that we should optimize the drug. So if the one drug is not effective, use second drug, because the uterotonic, the oxytocin receptor are different. Especially if you have given oxytocin for induction, then oxytocin might not help. You have to resort to the methylargometrin or the misoprostol. And always utilize that, give the good dose. You can repeat mergometrin 4 ampule, oxytocin up to 80 to 100 unit, misoprostol above 600 to 800 microgram, and PGF2 alpha around 8 dose. So it is important that you don't think that no, we will take to second level, we will take to OT. If you have given only one unit, you have to optimize. You can repeat it, and that is the thing what we have to understand. Tranexamic acid, after women trial have come to it. I was fortunate that the first trials, when it was presented in FIGO, I was there from Pakistan, from India. And tranexamic acid is a recommended drug. 2 things, when there is a high risk of PPH, you give prophylactic tranexamic acid. If it is a PPH, give it within the 30 minutes of diagnosis and repeat after 1 hour. But after 3 hours, tranexamic acid is not effective and sometimes may cause the adverse effect as well. Very, very careful that the tranexamic acid resembles the bupivacaine injection, and sometimes inadvertent injection as a regional anesthesia they have been given, and we have to be very, very careful because it causes a criticality as well as the mortality. When to think of blood transfusion, we obstetrician are like blamed always unnecessary. We call for the blood transfusion, but we have to be very careful. If ongoing moderate to severe hemorrhage, hemoglobin less than 7 gram, if there is a precedent, any chance for the coagulopathy like preeclampsia, HELP syndrome, IUFD, then we have to be very, very proactive for the availability of blood component, and the bedside blood test remains with us, because we talk of many coagulation, but in most of the setting we get at least report after 30 minutes to 1 hour, and after 1 hour actually it is a time to repeat in certain situation. So these are the simple tests you put into the test tube, and then you just rotate it. Thus you rotate it and you can see that solid clot is formed, and if this clot is stable or not. Massive blood transfusion, we talk a lot. In coagulopathy, we take this as 1:1:1, but in otherwise the massive transfusion protocol start after the 3 or 4 unit of PRBC has been given, and then there is a chance that we can have the consumptive coagulopathy or the dilutional coagulopathy, and then the according to PT fibrinogen level and platelet count, it should be considered. Dr. Nalini Mishra has published a beautiful paper that how these bedside tests correlates so well with the fibrinogen level, and we should be very confident in using it. These are certain theoretical goals which we wish to achieve with blood transfusion. We don't want the patient to be anemic 5 or 6 grams. We want to have 8 gram hemoglobin, 75,000 platelet count, prothrombin time less than 1.5, and the good vitals, that is systolic blood pressure. Ready with the PPH trays and the trolleys, and this is important, and we must have our own transvaginal uterine artery clamp, Samartha Ram section, because these are a one-time investment, and you never know that at what moment of time you might be able to need it. Always record event, good communication in worst of circumstances. We are having, even Dr. Usha Na's hospital, we have the Manyata certification. So you can join Manyata, so your nursing staff is readily diagnose PPH and give the initial management. Cause analysis as per the thing, if it is a inversion, if it is a retained placenta, you have to do. Bimanual uterine compression, again, this is the art, and SR cannula Samartha Ram is not with us, but it is something very, very important, that how it, by the physiological principle of the contraction and retraction, it is almost 90% effective, especially in the atonic postpartum hemorrhage. This is very important. Take swift decision. If you think that this patient to be shifted to OT, you have to take very, very swift decision. If there is a cervical tear, never do half-heartedly. Good anesthesia, good assistant, and all suture material, all type of the sponge holding forceps must be there. And what I was saying, that Dr. Pally's transvaginal uterine artery clamp, this is simple instrument which give you time to manage, so that patient does not pass into irreversible shock, time to refer, and sometimes it corrects also. So Dr. Pally has got its own research division and research officer, and that is the way that we should really do. Nalini has done a remarkable job in creating Chhattisgarh balloon and MRP. If there is a retained placenta or possibility of retained placenta, then important thing is mobilize the team. Don't wait for 30 minutes, 40 minutes, 60 minutes, because sometimes you get sudden shock. Sometimes you get sudden unexplained the cardiac arrest or something by the time anesthetist comes. So if their placenta is retained for 15 to 20 minutes, time to mobilize it. Coagulopathy is something which is in our country: dengue, malaria, SLE, viral infection, autoimmune, drug-induced thrombocytopenia. And here is the thing where we have to have a good bridging the gaps in the knowledge. And this is the thing that always think for shifting the patient to OT. If the uterus is flabby, legs, pouring blood with unstable vitals, you are not able to suture high cervical tear, indefinite contour of uterus, so either it is inversion or rupture, lump felt per abdominally or vaginally, and take early and prompt decision. When you are shifting, you can use NASG, bimanual compression, aortic compression, all skills what we are doing. So finally, it is save lives. Drastic situation need aggressive measure. We have to be ready with our all equipment, all drugs, all team, good cause analysis, and whenever needed, optimize the resuscitation and medical management. But if you think it is needed, you go on to the second level of measure. So if you can fill the unforgiving minute with 60-second worth of distance, run, run, run. So leadership is all commitment and conviction. And once again, First of all, thank you for all your loving words and support for my presidential candidature. And I wish that every one of you vote not only for me, you ask 20 to 50 people to vote for me, because together we can make a change. Thank you very much. Thank you, very much.
Madam. It was a very wonderful and informative session.
Thank
May
you,
I
Sadhna.
request Dr.
Just a
Mamta
minute.
Datta
Mosmi,
Madam,
just a
to
minute.
give her remarks.
1 minute. Mosmi.
Yes,
minute.
madam, yes.
Thank you, Sadhna, for your excellent talk on PPH. Just one thing I want to tell you people also. I have opened the Emergency Obstetric Care Center in the RIMS in 2007 to reduce the maternal mortality. That was from the government of India. And I think everybody knows the Sadhna Gupta is a candidate for the coming president. I request all the Jharkhand members to support her and give the vote. And I assure Sadhna that from Ranchi society especially, we will support you and you will win. You are eligible candidate. Thank you. Thank you, Mosmi. And thank you all the Jamshedpur organizing a committee, organizing members for calling me. I'm not well, Mosmi. That's why.
Thank you, madam, for joining. I know you had told me that you had a cataract surgery just 2 days back. In spite of that, your time and your valuable blessings are very important to us. So, ma'am, may I request Dr. Mamta Datta, madam, to give her remarks?
Thank you, Moshmi. Thank you, Sadhna, madam, for an excellent talk on the PPH. And I salute your commitment to the cause of women health and to the cause of Foxy. So after a speaker like Sadhna, madam, Moshmi, I do not dare to provide any remarks, but it was a wonderful talk on all the aspects of PPH, the incidents, the why do women our mothers are dying, why our mothers are dying, the management, the assessment of blood loss, the conservative managements, and when to go in for surgical management, all have been explained in detail, and I'm sure all of us have benefited with this. Excellent talk. Sadhna, madam, we most of us look forward to the clinical pearls of wisdom that you share with us regularly, and we wish you all the very best for the upcoming elections, and you have all our support for the same. I thank you for having invited me to be chairing this prestigious session, and I also wish to convey my regards to all my seniors, Rangila ma'am, Devdas sir, Usha Nath ma'am, and all the seniors who are present in this meeting. Thank you so much.
Thank you, madam. I thank both the chairpersons and Sadhna madam for this session 1. So we're now moving to session 2. Chitra, can we have the slide, please? The session 2 is skill demonstration on refractory PPH by Dr. Nalini Mishra. The chairpersons are Dr. Suman Sinha and Dr. Roma Yadav. Dr. Suman Sinha, ma'am, she's the president of Ranchi Obs and Gynae Society, senior consultant and infertility and IVF specialist, director in Advanced Care and Maternity Center, Ranchi, vice president of Society of Vaginal Surgeons of India, Bihar and Jharkhand chapter, and she's the organizing chairperson of Foxy East Zone Conference, UVA, with various publications to her credit. I welcome you, ma'am. We have Dr. Roma Yadav with us. She is the vice president of Bhagalpur Obs and Gynae Society, member of MTP Committee Foxy, member of MTP Committee Bhagalpur Obs and Gynae Society, past secretary of Bhagalpur Society, and also IMA branch of Bhagalpur. I welcome you. I welcome both the chairpersons. So may I request, madam, to please introduce our speaker and start the session.
Thank you. Good evening, everybody. Thank you, Dr. Moshmi, for the kind introduction. And now I take the honor to introduce a great scholar and academician, Dr. Nalini Mishra, madam. I recollect the memories of her during our PPH workshop at Ranchi. We had first time learned how to make uterine balloon tamponade, and that was her discovery. She taught us the Chhattisgarh balloon tamponade, and today we are going to listen from her the Chhattisgarh tape. So a big welcome to Dr. Nalini Mishra, madam, and we are eager to hear from you. Over to you, Dr. Nalini.
Thank you so much, madam. Mosmi, please carry on. I think we should start. Thank you so much, chairpersons. My God, I remember those days when I came to such fond memories of you people, such loving society, loving people.
I am Dr. Nalini Mishra from Bhopal. Chhattisgarh drape is an innovative low-cost drape which is prepared of plastic apron. This is used for visual estimation of blood loss after vaginal delivery. You can prepare it at the point of care. What we need is a plastic apron. This is very easy to make, use, and can be disposed in the yellow bag, and it detects PPH in real time. It costs around 15 rupees each. The vertically folded plastic apron is taken, and the lower edge of this vertically doubled plastic apron is sealed with the help of a plastic sealing device. It takes only few seconds, and the completion is denoted by the sound of a beep. This lower portion of the plastic apron, which is now sealed, is unfolded in a manner that it forms a cone, as you can see. This cone is used and is denoted at 10.5, 12 and 15 centimeters with the help of a plastic scale, and it denotes the volumes of 350 ml, 500 ml and 1 liter. The neck piece of the CG, this drape is cut, or the plastic apron is cut. Now the cone of this CG drape is folded under the woman who is in the first stage or early second stage of the labor, and the belt which we use to tie the apron on our back is tied in the front of the abdomen of the woman. This forms the lower belt. Now the neck piece which we have cut, the two ends will serve as the upper belt, so that all the blood is siphoned into the cone and does not spill here and there. After the baby has delivered and amniotic fluid has drained out, we ask the woman to lift her buttocks a little, and we unfold the cone like this. Then the whole blood after the delivery of the baby is collected in this cone or pouch and can be measured in real time. You can dispose this CG drape in the yellow bag along with the placenta and other tissues. If the woman is having a tonic PPH, not responding to medical management, we have to go for the second bundle, and intrauterine balloon tamponade is an important component. And when do we use the UBT? When the obstetric shock index is crossed 1 but is still less than 1.5 is the ideal time to use this. So I will be describing two devices. One is Chhattisgarh balloon and another is easy balloon. Chhattisgarh balloon has a central drainage port, whereas easy balloon is more of a conventional condom balloon tamponade. So how do we make Chhattisgarh balloon? We need a Foley's catheter with a bigger French, condom, scissors, 2 syringes of 10 or 20 ml each, cell line, and we prepare it in all the aseptic precaution from the steps A to F, A, B, C, D, E, F. So A is for air, remember A for air. So introduce air with the help of a syringe and inflate the bulb of the Foley's catheter, and then it is wound round over another finger so that the shaft is out of the way, because we are now perforating the bulb of the Foley's catheter, and this perforation is extended all around the circumference of the Foley's catheter. So now we have resected the bulb and the cut ends are everted up and down. This will expose the hole on the shaft of the catheter in the area of the bulb. Now we are moving to B. B is to make the bulb. So we are replacing the bulb of the Foley's catheter with a bigger bulb which is prepared of the condom. So roll the condom over the catheter. Now we come the C. So C is cutting 2 rings from the urinary drainage port. At the end of the urinary drainage port, prepare 2 rings just like rubber bands. Now this was C, and D is double application of these rings. So first of these ring is applied in the upper portion of the exposed area of the bulb, so in the neck. Then the second ring is taken and it is applied in the lower portion of the condom, 1.5 to 2 centimeters away from the rim of the condom. So this is double application of the ring. Now comes the E. So we have to excise the tip of the condom and tip of the catheter together at the level of middle of the urinary drainage hole. This will create a hole at the top. This is then in this CG balloon is then dipped into the betadine solution for at least 3 minutes. We cut a bottle of normal saline like this and expose. You see it in the CG drip, the blood loss is more than 1 liter. OSI must be more than 1. Expose the cervix with the help of 2 big speculums. Always keep big speculums in your PPH tray. Then catch hold of the anterior and the posterior lips of the cervix and take out the Chhattisgarh balloon from betadine. Keep it in between your 2 fingers and insert inside the uterine cavity. It goes very easily till the rim is reaches the level of the upper portion of the os. After that, we are going to pack the vagina with a big dressing pad or an autoclaved pad. This is done, and after that the urinary drainage port will be connected with the urosec, because this will be draining the blood which is going inside. You can see the blood which is inside the uterine cavity is now can be seen in the tubing of the urosec. Since we have replaced the bulb of the Foley's with a bigger bulb made of condom, so we have to inflate it through the bulb inflation port. So take the syringes alternatingly, and one person fills the syringe, another person inflates the bulb through the bulb inflation port, and this is done till either the resistance is felt or the column in the tubing stops moving. So that is the hemostasis. So once the hemostasis is achieved, we can now proceed further. You see the nicely inflated bulb inside. Then we catheterize the bladder, mark the margins of the uterus, and then put her on oxytocin drip, give her antibiotic. Of course, you can prepare the CG balloon. There are many advantages. The bleeding can be assessed through the drainage port connected to the collection bag, and you can pack the vagina. So it takes care of the expulsion of the UBT, which is the biggest problem in conventional condom balloon tamponade. You can always prepare CG balloon in advance and get it ETO'd and then keep it ready for use. In case you are forgetting these steps or there is no one and suddenly the emergency has struck, so anybody can make a very easy variety of condom balloon tamponade, and that is easy balloon, that is really easiest to make. There is nothing much in that, it's more of a conventional condom balloon tamponade. So again, take any size of Foley's catheter, prepare 2 rings. This 1 millimeter ring is cut from the end of the urinary drainage port. Then the condom is rolled over the Foley's catheter, the tip of the Foley's being in the tip of the condom. Then take 1 ring and apply it 1.5 to 2 centimeters away from the rim of the condom. So this 1 ring is applied twice, only do it twice. So this is done. So it's how easy it is to make the easy balloon. After that, you dip the UBT which we have prepared in the betadine, expose the cervix with the help of 2 big speculums, and catch hold of the anterior and the posterior lip of the cervix with the help of 2 sponge holding forceps. Now take out the easy balloon from the betadine and then insert it inside the uterine cavity. It again goes easily till the rim of the condom is visible in the upper portion of the internal os. This must go as at least this far in, and we have to visualize the bleeding at the level of the internal os. Now, how do we inflate it? We have to inflate it through the urinary drainage port by connecting an IV set to it and IV normal saline. So, the saline goes through the catheter into the bulb of the which we have prepared in the by inserting the condom over the catheter. So, the saline goes easily and you have to do it till the bleeding stops. Once the bleeding stops, now we have to occlude the distal portion of the Foley's catheter. So, that is done by folding it and applying the second ring 3 times over the folded lower end of the Foley's catheter. Remember it, we have to do it 3 times so that the fluid doesn't come out and the UBT is not deflated before time. Once this is done, check the bleeding again, it is stopped, and then take out the speculum and pack the vagina with a big, again with either a big sponge holding, big dressing pad or a big autoclave perineal pad. So then mark the margins. When we have to deflate it, just pull out the 2 ends of the Foley's catheter, the ring will just get away, and this can be done 6 to 24 hours later. When we talk of CG drape, CG balloon or AZ balloon, these are all the local innovations and can be prepared at the point of care. There is nothing commercial about it. I'm proud to be Indian. Thank you so much.
Really amazing, Dr. Nalini.
Fantastic.
We would
Fantastic.
like to hear it again and again and see it.
Madam Nalini, madam, we are having critical care conference on 1st and 2nd December in Bhagalpur. I am inviting you. You will demonstrate there. Okay.
Sure.
So
Good evening, ma'am.
That
Good
gives
evening.
me the greatest joy. You see, whenever I am there at hands-on conference, any hands-on workshop, I am happiest.
True. Fantastic.
We are
Fantastic.
calling you, madam.
Good evening, madam. Good evening, all. This is a real wonderful presentation. This is a very good presentation for the beginners also, and for the staffs and the nursing staffs working at the periphery level. They can prepare this easy balloon very easily.
Yes.
Name is as name suggests, they can prepare very easily and they can use it. Main problem is in case of this PPH or refractory PPH, the people should do immediately to faster action. And whenever the patient comes from periphery to us, it goes in a condition of irreversible shock. And then it's very difficult to make the patient safe and comfortable. So
Actually, madam,
I
when
think
they refer the patient, they should put in the balloon and
Yeah.
then
True,
the
true,
and
true,
put
true.
on oxygen and IV drip, and then only they should refer.
Yeah, they should refer along with this balloon. That
Yes.
should be that is the take-home message of your madam presentation. And as Kavita told, that we have a critical care management, critical care workshop in the month of December on 1st and 2nd. We will call you, and we have a session for the nursing staffs there also. And and you demonstrate all these things. Wonderful video presentation.
Doctors and for nurses, हम लोगों को भी juniors
For the nurses, for the nursing staff, it's very necessary.
My privilege.
Ma'am, you can share this video presentation to our groups also, so that we can show it to our nursing staff.
Yeah, madam, this should be shared in the group. So
In
that
this
we
session
can,
also. Yeah.
So that we can share to all the nursing staffs in periphery also,
Even
and in
for
the
us,
PSC and
in our group
and
also,
for
so
the
that-
hospitals.
And one more question. In this easy balloon, you said that we have to push in normal saline through the urinary output. But what about the balloon, this thing? We have two now. One is to raise the balloon of the
bulb.
देखिए तो सीधी बात बताऊं, देखिए सीजी बलून जो है ना, हम लोग फोलिस कैथेटर जब ब्लैडर में डालते हैं ना, तो हम कैसे इन्फ्लेट करते हैं, हम उसको बल्ब इन्फ्लेशन पोर्ट के थ्रू इन्फ्लेट करते हैं ना।
इसको कुछ नहीं करना ना, वो बल्ब वाले को कुछ नहीं करना है, वी डोंट हैव टू टच इट।
हाँ, तो बल्ब वाले को जब सीजी बलून में हमने जो उसका बल्ब से कॉन्डोम वाले से, ठीक है, लेकिन जो इजी बलून है ना, उसमें हमने बल्ब को कुछ भी नहीं किया है। तो इसमें हाँ, जो सीधे यूरिनरी, क्योंकि जब हम सीजी बलून में करते हैं तो हमको जो कि बल्ब में वो डालना, इसलिए हमको पॉजिटिव प्रेशर से डालना पड़ता है। और जब इजी बलून जो है उसमें आपको सीधे सीधे जो आईवी लाइन
गॉट इट,
यूरिन जहाँ से ड्रेन होती है उसमें आप लगा दीजिए, आराम से जाता है। और एक और टिप मैं देना चाहती हूँ कि whenever you feel that now in CG balloon, either you start feeling resistance, inflation,
then you have to stop.
Balloon, when you see that the drip rate is, then you see, look for the amount of bleeding, and generally that is the time when the tamponade is achieved. तो ये एक उसका टिप है। एंड जनरली क्योंकि you are doing it under direct observation ना, so you tend to inflate it with a slightly smaller volume. तो
Yeah, मैडम, तब ये कलेक्शन जो which is getting there, how it will come out? अगर हम पूरा उसको फिल कर दिए बैलून क्रैम्पोनाट से, तो whatever the collection is inside the vagina, how it will come out?
सब निकल जाएगा।
नहीं, वेजाइना नहीं, जो कलेक्शन यूट्रस,
I mean
नहीं, then it cannot come out, डॉक्टर नलिनी, इसलिए एक चीज उन्होंने बोला है फंडल हाइट को मार्क करने के लिए। फंडल हाइट इसलिए मार्क होता है कि अगर बाई चांस आपका कलेक्शन होते रहता है तो वो फंडल हाइट बढ़ता रहेगा, आपको फिर रियलाइजेशन हो जाएगा कि आपका यूबीटी का प्रेशर एडिक्वेट नहीं हुआ है, आपको फिर ज्यादा प्रेशर डालना पड़ेगा।
तो अगर हम जैसे हम कैथेटर को करते हैं इन्फ्लेट, वैसे उस साइड से क्यों नहीं इन्फ्लेट करें?
नहीं, क्योंकि उसमें आपका एक फोलिस कैथेटर का बल्ब का आपका मैक्सिमम कैपेसिटी 40 to 50 सीसी होगा।
नहीं, कंडोम अगर हम उसको फिक्स कर दिए और जिससे हम
आपका जो इजी बलून है उसमें आपका जब जो कैथेटर के बल्ब से नहीं हो रहा है ना, आपने वो फोड़ा नहीं है, मतलब यू हैव नॉट कट दैट कैथेटर बल्ब। जो सीजी बलून में उन्होंने किया है, इसलिए थ्रू सीजी बलून आप कैथेटर मतलब कैथेटर के बल्ब से कर सकते हैं,
उससे ज्यादा बढ़ नहीं पाएगा।
सीजी बलून में ब्लीड, जो कलेक्टेड ब्लड भी निकल जाता है।
हाँ, सीजी बलून में यू कैन सी कलेक्टेड ब्लड, इजी बलून में
कलेक्शन वो निकल भी जा रहा है यूट्राइन कैविटी से और चोक भी कर रहा है, माने टोनिसिटी भी कंट्रोल कर रहा है।
देखिए एक मिनट, यूबीटी के लिए एक फंडा बहुत क्लियर होना चाहिए कि अगर ब्लीडिंग हो रहा है तो आपका यूबीटी अभी तक इफेक्टिव नहीं हुआ है। वंस यू हैव इंसर्टेड द यूबीटी और आपने यूबीटी को इन्फ्लेट कर दिया है, ब्लीडिंग टेक्निकली शुड स्टॉप। तो ये बहुत इंपॉर्टेंट है कि यूबीटी स्टॉप होना चाहिए, ब्लीडिंग स्टॉप होना चाहिए अगर आपने यूबीटी डाला है। अगर यूबीटी के बावजूद भी अंदर में ब्लीडिंग हो रही है तो कहीं ना कहीं आपका या तो फिलिंग गड़बड़ है या डॉक्टर नलिनी इज रीजॉइंड।
तो पैनिकल सक्शन कैनुला टैम्पोनेट जो है वो भी तो है, सक्शन कैनुला सक्शन कर रहा, उसके बाद फिर
एसआर कैनुला एंड यूबीटी डोंट, हाँ, ये दोनों अलग अलग चीज है, दीज आर टू डिफरेंट थिंग्स।
आई नो वो पहले वो कोलैप्स कर दिया, कैविटी को क्लोज किया, उसके बाद फिर हम अगर मान लीजिए उसको कोलैप्स करा
नो, आप सक्शन कैनुला करने के बाद यूबीटी नहीं यूज कर सकते, ये कॉम्प्लीमेंट्री नहीं है, ये स्लैश या तो ये यूज कीजिए या फिर वो यूज कीजिए।
यूबीटी के बारे में मैं एक चीज बोलना चाहूंगी, इफ आई हैव 1 minute टाइम। देखिए, व्हाटएवर यू सी एनी गाइडलाइन, right from FIGO to WHO to any guideline, government say that the first line management is not effective, then you go for balloon tamponade. जो care bundle है उस motive and the second जो है second bundle में there is balloon tamponade. So every recommending for uterine balloon tamponade as a first step in the second line intervention. So correct. After compression, then because if you are going according to the guideline, you are safe in the court of law. क्योंकि कोर्ट में किसी दिन फंसेंगे तो वो आपको ये पूछेगा कि क्या किस गाइडलाइन के अकॉर्डिंग आपने बलून टेम्पोनेट यूज किया. यू कैन कोट एनी गाइड.
Yes. Very nice.
इम्पोर्टेंट
Thank
थिंग,
you.
एक बार यूबीटी डालने से पहले वन वेरी इंपॉर्टेंट एस्पेक्ट इज दैट यूट्रस शुड बी एम्प्टी. तो अगर आपको लगता है कि आपका मतलब प्लेसेंटल
Clots है.
रिटेन बिट्स है या कुछ है, क्लॉट्स है, तो प्लीज इवैक्यूएट एंड देन इंसर्ट द यूट्राइन बलून टेम्प. बाद में फिर वो डाउट नहीं रहेगा कि अंदर में क्लॉट था या नहीं था. दैट
मैडम
इज
वो सारे
अनदर
टीज
थिंग.
में से ना ये वाला टोन वाला टी ही होना चाहिए जब आप
यस
डालते
यस,
हैं. हालांकि
दैट इज इम्पोर्टेंट.
अच्छा, एक चीज और है कि कभी कभी ऐसा होता है कि वेजाइना में अगर if there is a huge tear or laceration, you have to go for the surgical methods first. But many a times the patient is referred and it's all friable and करने के लिए cut through हो जाता है, it starts pouring. In those cases also you can use the tamponade in the about that. You can also use this in cases of जैसे hepatitis E वाले, when you know कि आप बहुत सारी medicines नहीं दे सकते, उसका surgery नहीं कर सकते, you can use there. If there is uterine fibroid, इंट्रा सबम्यूकस फाइब्रॉइड है जिसकी वजह से पेशेंट ब्लीड कर रही है, हमारे अभी कुछ 2-3 पेशेंट में ऐसा हुआ, देन द टेम्पोनेट वर्क्स ब्यूटीफुली बिकॉज इट एडजस्ट इटसेल्फ.
आवाज चली जा रही है बीच बीच में.
हाँ,
उनका नेटवर्क थोड़ा सा पुअर है.
हाँ, मैं ये बोल रही हूँ सबम्यूकस फाइब्रॉइड से अगर पीपीएच हो रहा है, देन टेम्पोनेट वर्क्स ब्यूटीफुली.
Perfect. Yeah.
Fine. Very nice.
Yeah.
That is a very good indication.
I'm a great fan of UBTs because I've been using UBTs very regularly, and I've saved a huge number of lives by using with UBTs. In fact, I was telling Dr. Nalini when I met her in Calcutta, like I use at least one UBT every 2 months. में तो मेरा एक UBT मेरा use हो ही जाता है.
तो मेरा twin pregnancy में always I use UBT.
PPH होता है मेरा. UBTs is my first line of refractory PPH में very important.
Twin pregnancy cesarean I give UBT so that I can sleep at night.
नहीं, हम रूटीन नहीं डालते हैं. I only use it अगर PPH होता है as a second line therapy.
Not CG balloon नहीं, easy वाला जो है ना उसको मैं डालती हूँ. Twin pregnancy and if I take that case in the night, I do make a point to put it. So very nice talk from Dr. Nalini. We all have been enlightened, and I hope everybody is going to use the Chhattisgarh.
I just had one question. I think Dr. Nalini ka network thoda poor hai. Anyway, मतलब वो बात है. I was wondering how she keeps that brass feed drape open because जो इनका material दिख रहा था वो चिपक रहा था.
काटने वाला कैसे है वो नहीं समझ में आया.
जब आप खोल देते हैं ना उसको,
अच्छे वो काटने वाला समझ में नहीं आया हम लोग. कहाँ से काट के बांधने वाला क्या हुआ? How to make that?
तो ऊपर के स्ट्रैप्स हैं जो आपका
वो कैसे बना?
तो उसके नीचे से काटे तो ऊपर वाला बच गया, उसको बांध रहे हैं.
हाँ,
है ना, उसके ऊपर से ऐसे बांध रहे हैं और ये कौन बना रहा है.
वही तो पता नहीं चला.
Thank you. Yeah, thank you Nalini madam for the wonderful.
हम लोग नलिनी मैडम से ले लेंगे, तब फिर देखेंगे तब बनवाएंगे.
Chhattisgarh balloon I had seen before, but I first attended it in AICOG Bengaluru. I think 4-5 years back when we had AICOG Bengaluru in PPH workshop, she was there and she was the faculty there who had hands-on workshop there. So thank you, madam. Nalini madam, as usual, excellent. And I thank both the chairpersons for their wonderful discussions and coming up with all the clarifications. So now moving on to the next session. Moving on to the next session, I request my co-convener, Dr. Ayushi Agarwal, to take on. She is an ex-senior resident of AIIMS Gorakhpur and now a consultant at Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. So over to you, Ayushi.
Thank you so much, ma'am. And we begin with the third session, which is a panel discussion on common case situations in postpartum hemorrhage. So I would like to invite our moderators. We have with us Dr. Maushmi Ghosh, ma'am. Ma'am is consultant at Tata Main Hospital, Jamshedpur, Manipal Tata Medical College. Ma'am is active member of Jamshedpur Obs-Gynae Society. Ma'am has organized first All Jharkhand Conference. Ma'am is a postgraduate teacher and guide, awardee of Kamini Rao Orator East Zone Award 2017, Indumati Jhaveri Award, Bani Saman. Welcome, ma'am, once again. Dr. Apurva Kumar Datta, sir. Sir is MBBS MS consultant at Shri Durga Clinic and Fertility Center, Dhanbad. Sir is a national coordinator for FOXY CME workshop for safe abortion and contraceptive care 2020. National coordinator FOXY Sexual Medical Committee, regional faculty and master trainer TOT Sat. Executive founder, member of Jharkhand State Chapter of International Spina Bifida Foundation. Sir is awardee of many awards, as we can see the list. FOXY Dr. Shanti Yadav Award for Infertility, Dr. Rangila Sinha Young Gynecologist Award 2022, FOXY Appreciation Award 2022, and many more. Warm welcome, sir. We have Dr. Nivedita Datta ma'am as expert panelist. Ma'am is president of Bokaro Obskyny Society, consultant KM Memorial Hospital and Research Center Private Limited, Bokaro. Ma'am raises the awareness and concentration in rural areas of Jharkhand. Ma'am is associated with NGOs, National Health Systems, UNICEF, CEPOC, and many more. Ma'am is supporter of FOXY's Manita and serves in as various roles as trainer, assessor, and coordinator in Manita program. Very warm welcome, madam. Next, I would like to invite our esteemed panelists. We have with us Dr. Ranju Jha, ma'am. Ma'am is consultant gynecologist at NGM Hospital, Jamshedpur. Ma'am is associate professor over there. Ma'am is member advisory board, Jamshedpur Obskyny Society, former vice president and former CME secretary of Jharkhand Obskyny Society. Welcome, ma'am. Dr. Sunita Murmu, ma'am. Ma'am is consultant, Department of Obskyny at Tata Main Hospital, Jamshedpur. Assistant professor at Manipal Tata Medical College, Jamshedpur. Warm welcome, ma'am. Dr. Ela Roy, ma'am. Ma'am is has a training in Obskyny for 2 years at Central Hospital, Dhanbad. Mini lab training at SNMMCH, Dhanbad. Cervical, breast and oral cancer at TMC, Kolkata. Emergency obstetric and newborn care at RIMS, Ranchi. Ma'am has been ex-medical officer at Divisional Railway Hospital, Dhanbad, and active in health camps in coalfield rural areas of Dhanbad. Welcome, madam. Dr. Meenakshi Kumari, ma'am. Ma'am is consultant gynecologist and sonologist at Kushi Clinic, Ranchi. Ma'am is assistant associate professor at MGM Medical College in the duration of 2011 to 2015. Worked as joint secretary of Ranchi Obskyny Society from 2019 to 21. FOXY MTP committee member 2021. Ma'am has many peer-reviewed journals and special interest in fetal medicine, high-risk obstetrics. Welcome, madam. Dr. Varsha Sinha, ma'am. Ma'am is postgraduate from Kasturba Medical College, working as a consultant gynecologist at Jagannath Hospital. Ma'am has been awarded as a first prize winner in paper presentation in TNOGC. Very warm welcome, madam. Dr. Kavita Banwal, ma'am. Ma'am is senior consultant and laparoscopic surgeon at Samarpan Hospital, Munger. Honorary teacher at Lord Buddha Koshi Medical College and Hospital. Recipient of Padma Bhushan Kamla Bai Hospital Award. Member YTP Committee FOXY 2001 to 23. Associate member of RCOG, presented paper in RCOG 2023. Received YTP Champion Award twice. Organizing Secretary of 9th AOG SPJ in 2022. Ma'am has organized many rural camps and done awareness program with special areas of interest in high-risk obstetrics and hysteroscopy. A very, very warm welcome, madam. So I hand over the session to Moshmi, ma'am.
Yes, thank you, Ayushi. Good evening, dear panelists. My co-moderator, Dr. Apurva Datta, he is sick, so I will be moderating the panel. We have 4 case scenarios to discuss. 4 very common scenarios we all face in labor room in day-to-day practice. So we have, my work is very easy today because we have a whole galaxy of learned and experienced obstetricians with us in the team. So we will put up a case scenario and look for different ways how to tackle it. And if there is any tie, then we will look forward. We have an expert panelist with us, Dr. Nivedita Datta. So we now move on. So just a brief introduction. PPH, we all know, is responsible for 25 to 30% of all maternal deaths worldwide, as high as 60%. It causes 100,000 maternal deaths per year worldwide. And traditionally, it is more than 500 ml blood loss in vaginal delivery and more than 1 liter during cesarean section. Primary PPH and secondary PPH. Primary PPH is within 24 hours. Secondary PPH is after 24 hours. And golden hour is when the best time when resuscitation should be done. So diagnosing PPH is not the problem. So when we diagnose PPH, diagnosing PPH is very easy. But the golden hour, what to do, when to do, and how much to do is the million-dollar question. Causes of PPH, 4 T's: trauma, tone, thrombin, and tissue. So PPH tests the functioning of health system and the skill of the health workers. It is often unpredicted and presents like a thunderbolt because the patients can deteriorate very rapidly after the onset of PPH and can die in short span. So it actually, PPH actually shows us the teamwork in labor room, the coordination and teamwork between the doctors, senior doctors, the residents, the nursing staff, and the OT staff. So coming to case scenario 1, 38-year-old primary gravida, twin pregnancy, DCDA twins conceived after IVF treatment, admitted in labor at 35 weeks gestation. On admission, she was cervix was fully effaced, 3 centimeter dilated, thick meconium, and ultrasound showed first fetus was in cephalic and second transverse lie with good fetal weight of both the twins. Cesarean section was done as by 10 p.m. and then intraoperative period was uneventful. Both babies were active. Now, let us start as what preventive measures should be taken in this case. Can we start with Ranju Jha, madam?
Because there is over distension of uterus, so there may be a chance of atonic PPH. So we should give prophylactic oxytocin or carbitocin during operation. Yes.
So she's a case of twin pregnancy. She's a case of elderly lady with twin pregnancy and also post-IVF pregnancy with emergency cesarean section done. So all these makes it a high-risk case. So we should actually anticipate PPH and take all preventive measures in this case.
I think, yeah, transgenic acid should also be given. Bladder should be catheterized. Indwelling catheter should be put. And along with this carbitocin or oxytocin, we can give misoprostol also.
Yes,
because
so medical
both
management.
of the different mechanism action. So I think this should be done. And always there should be close monitoring.
But WHO has not recommended.
She can bleed. Yeah.
Right, right, ma'am.
But WHO has not recommended two types of
prophylactic tranexamic acid also.
Right.
Yeah, we can give,
So,
but the WHO has not recommended use of oxytocin and misoprostol side by side. They have recommended only use of oxytocin, but it is not beneficial. It has been seen by a randomized trial. It is not beneficial if both are given.
and after
But we can give prophylactic tranexamic acid.
Yes. Tranexamic acid 1 gram, definitely we can start because it has the role is defined. Now, after 2 hours of cesarean section, that is at 12 a.m., sister, she's in the post-operative ward where she's monitored. The sister now calls for PPH, and when we examine her, she has mild pallor, pulse rate is 130, blood pressure 100/70, uterus is atonic, she's passing clots, bedsheet is partly soaked with blood. So how do we approach to manage this case? Now we move to Dr. Ela Roy. Dr. Ela Roy.
Dr. Ela Roy is there?
Yes. Yes, madam. Dr. Ela Roy.
Ma'am, initially we first do the rapid initial assessment first taking all the pulse rate, the BP, and initial we have to put our hands on the abdomen to see the tonicity of the uterus. If the uterus is atonic, then we start the uterotonic drugs. The oxytocin, we start the IV drips. In the first 500 ml of Ringer's lactate or normal saline, we start with 20 units of syntocinon, what I do in the periphery. And then in 15 to 20 minutes, it should go if the patient is going into shock. And again, we start another IV drip. And then we have to see whether we have to take the, at the same time, coagulopathy. We have to see whether she has any coagulable disorders. And then after this, we have to give the trinaxamic acid. I use the injection Trenexa, 1 gram. I tell whoever is there, we have very little manpower in our setup. So we put all the, whoever staff is there, they are all trained to do in the labor room. We have to have the PPH protocol, and then we have to start all the medical managements of this.
Yes. So it is the critical steps are call for help, resuscitation with fluids, and then arrange for blood, investigate the cause of bleeding, as you had said. And in medical management has already been started. We can go with the profile, with the
and ma'am,
increasing the dose. And
also one I do, which is very useful, is the bimanual compression of the uterus if the tone is not there, and also the aortic compression, abdominal aortic compression I do, and it has become very helpful for me.
Yes.
Putting the other hand on the femoral pulse to see once it's obliterated means the enough pressure is going. It has arrested many PPH.
Yes, ma'am. So now,
just a minute, Dr. Mashmi, sorry to interrupt. Is this woman, to the panelist, is this woman in shock?
Yes, ma'am. If we have to assess
the
patient, please, just a moment. Please go back to her findings. Her pulse rate is 130. Her blood pressure is 100/60. My question is very clear. Is she in shock? Yes or no?
yes.
What is a shock index? What is a shock index?
Shock index, systolic pressure, the heart rate by the systolic pressure. We measure.
So what is the shock index here? And that's what I'm asking you. Is it less than 1 or more than 1?
Ma'am, let me calculate.
It's simple, yeah. Her heart rate is 130. It is more than 1. Her heart rate is 130. Her blood pressure is systolic. Yeah, it is more than 1. So your woman is already in shock. She is already in shock.
She's in shock.
You are pretty late in management. She is already in shock. Now, that is what I'm trying to say. So you have to start with be very particular about this thing. See, she gave a very clear vitals about 130/100, 130 and 100. Your woman is in shock and you manage as per shock.
So resuscitation and
resuscitation as well as controlling of bleeding. 2 things very clear.
Hand in hand. Both should go simultaneously. Yeah, thank you. So now this estimated blood loss was around 1 liter. The patient received 2 Paxils. We have given her oxytocin. We have given her injection tranexamic acid, and intrauterine balloon tamponade was also done for this case. As Nalini madam has already explained, CG balloon and easy balloon. So medical management, tranexamic acid and balloon tamponade all done, and now patient is stable. Again at 2:30 a.m., sister called for PPH. There is pallor. Pulse rate again is 144. BP 94/66. Uterus is again atonic with again ongoing blood loss. So what is the next step of management? Can we go have Dr. Sunita Murmu?
Good evening, Mashmi. I think this patient, she is already been managed with uterotonics, and she has been given intrauterine tamponade also. So now we know that the cause of bleeding is atonic PPH, but the patient is not responding to intrauterine tamponade. So now we will think of the taking the patient to the OT again, and then we will do we will reopen that case, and then we will go for compression sutures and compression sutures, and simultaneously we will do selective devascularization. First of all, we will tie the uterine artery ligation, and then we will proceed for baleen suture. So and even if the bleeding is not controlled with this, then we will talk to the relatives, and we may proceed for sooner. We will proceed for hysterectomy in this case if bleeding is not controlled.
Yes, thank you, Dr. Sunita. So the patient is shifted to the operation theater. This is the 5th T in PPH, and the senior obstetrician should be involved in this case. So step-by-step compression sutures, selective uterine devascularization, and early decision for hysterectomy. The decision should be early, or else we might lose the patient. And blood transfusion protocol should be followed. So as we have seen in this case, so conservative measures should be tried first, rapidly moving to more invasive procedures. Will, skill, and drill of every health worker and obstetrician is important. There is a mnemonic to remember the steps, which is called hemostasis. H stands for ask for help, assess vitals, blood loss, and resuscitate. Establish etiology, massage the uterus, oxytocin infusion, shock garment when we refer the patient to a higher center, tamponade balloon, apply compression sutures, systematic pelvic devascularization, interventional radiology wherever the facility is available, and subtotal or total hysterectomy. So now moving to the second case. 28-year-old gravida 3 para 2, previous normal vaginal delivery, admitted in labor room at 38 weeks gestation in active labor. The course of her current pregnancy was unremarkable. The labor progressed normally, and the patient spontaneously delivered a 3.6 kg boy. No vaginal or perineal tears. Labor first stage and second stage of labor lasted approximately 4 hours and 30 minutes respectively. Placenta was delivered complete with minimal blood loss. Patient was transferred to the maternity unit 2 hours after delivery, and a normal contracted uterus without any evidence of abnormal blood loss. Now, 4 hours following delivery, patient complained of severe perineal and abdominal pain and was unable to void urine. On examination, she was pale, pulse of 100 per minute, blood pressure 100/60, per abdomen uterus well contracted, and uterus was at the level of umbilicus, and the right lower quadrant was extremely tender on palpation. Pelvic examination, no obvious vaginal or vulval swelling. On PR examination, no obvious boggy mass felt. Hemoglobin now was 7.5 gram%. Initially, it was 12, and urgent transabdominal ultrasound was done. This was the ultrasound finding, which showed a hypoechoic mass of 9 × 4 centimeter on the right side with a well-contracted uterus deviated to left. Can we have Dr. Meenakshi?
Good evening, ma'am. This is showing a...
Please be louder. Dr. Meenakshi, please come nearer to the mic.
Thank you, ma'am. This is showing a hematoma in the broad ligament.
Perfect.
As this is a patient is not in shock. Her blood pressure and her shock index is about 1. This is a case of hematoma, so it should be managed surgically. Patient, so after preparing the team, calling the surgeon and anesthetist, patient should be shifted to OT, and emergency laparotomy should be done. Patient should be resuscitated with fluid and all the blood transfusion, and if there is big hematoma, it should be drained. Along with it, the uterine massage and other things should be done to control the bleeding.
Uterine massage, but the uterus is contracted.
Uterus is contracted. There is broad ligament hematoma, so I think it should be evacuated. Only broad.
Yeah, it's a broad.
Yeah.
Yes.
And the uterine artery ligation can be done. Uterine artery ligation can be done because it may be cause of hematoma. So if there is any eversion of the uterine artery, any injury, so I think it should be ligated and evacuation of the hematoma.
So the diagnosis, the question was, what was the diagnosis? The diagnosis is broad ligament hematoma, which is very uncommon complication of labor.
Well,
now,
the labor
how do we manage? Yes, Kavita, madam, please go ahead.
Yeah, I think the patient should be shifted to the operation theater along with the resuscitation team. Senior obstetrician anesthesia also be called, cry for help, and laparotomy done. If there is hematoma, it should be evacuated. By the time blood should be arranged, all the initially should be crystallized, should be started in high dose, and thereafter, if blood is not available, we can go for colloids, and thereafter evacuation will be done, and the couch it is on the right side. So I think uterine artery ligation will help. So we will watch for some time, and then mostly it gets
Usually, it's very difficult to do uterine artery ligation in a broad ligament hematoma because of the there's a ureter is below.
It's difficult,
So you have
but
to
after
think of,
evacuation,
you have to do internal iliac.
hematoma,
You
we
have to do
can take
internal
it.
iliac.
Internal
internal
ligation
iliac,
we don't do because we don't have idea. So I have faced such situation in a primary gravida, and at the time evacuation was done, and I, by the way, blindly ligated uterine artery, and the patient responded. She did well.
Perfect. Perfect.
So,
Any other decision? Dr. Leena Nair. Madam, are you there?
Facilities are available, you can go in for uterine artery embolization if the facilities are available.
Yeah, absolutely.
Yeah, if the facilities of uterine artery embolization, it can be done.
Okay, then Dr. Varsha Sinha, any other things we can do in this patient? It is a case of broad ligament hematoma following a vaginal delivery, and patient is a multipara.
Ligation could be done. Go for hysterectomy if she doesn't respond to all the above management. If she doesn't respond to the
So just a moment. Hysterectomy is not going to be effective for a broad ligament hematoma.
I don't think hysterectomy should be done in first step.
First
because
of all,
there is hematoma of the broad ligament, not of the
absolutely.
uterus.
It's what has happened is that the uterine artery has ruptured.
Yeah.
Uterine vein has ruptured, and
Mostly there is
broad
avulsion
ligament
of the
hematoma. Uterine vein. So
Yeah.
you basically have to stop the bleeding from the uterine artery.
But sometimes the active bleeding point might not be more. In most of the cases, the active bleeder will not be found on laparotomy.
Absolutely. That is why an internal iliac ligation is.
It's difficult. Uterine artery ligation is difficult, but I have faced till now one case, and at the time I blindly took the ligation of the uterine dip, and the patient responded well. She went home. So mostly it's difficult. I know it's very difficult, but we are not trained in internal iliac artery ligation, and by the time the surgeon or other vascular surgeon comes, patient may get retrieved. So in our town, a smaller town, we don't have facility for internal iliac artery ligation.
Yeah. So exploratory laparotomy was done, and patient's coagulation status was assessed before blood products were arranged. On entering the peritoneal cavity, hematoma was found on the right broad ligament extending into the right paracolic gutter into the space of Retzius anteriorly. Exact location of bleeders could not be localized. Hence, a decision of subtotal hysterectomy was also taken. Hematoma was non-expanding. It was left undisturbed, and drains were put in situ. Patient received blood transfusion. Post-operatively, she was transferred to a high dependency unit, and catheter was removed. And then patient was discharged on day 10 in a good condition. So can we now move to the third case? This is a very common scenario in labor room, which was not there in the past. These are the recent phenomena of increasing cesarean rates. So gravida 3 para 2, previous two cesarean section referred by a private practitioner with ultrasound report of anterior placenta previa at 36 weeks 2 days. She is a case of beta thalassemia minor, hemoglobin of 7g%. She is a case of gestational diabetes mellitus on tablet metformin. Ultrasound was done at the higher center, which showed a fetus of 2.7 kg, A5 11 centimeter, placental tissue across the myometrium. Retroplacental myometrial thickness was less than 1 millimeter, and color flow Doppler showed turbulent lacunar blood flow. Now, my question to Dr. Varuna Verma. So this is the ultrasound picture. What is your diagnosis?
Madam, this is a case of placenta previa, and placenta actually we don't know whether it is reaching up to the placenta.
There is accreta.
It is a scar
pregnancy.
So any other diagnostic modality now you would like to, so color Doppler was done along with ultrasound and already,
also
done.
going for MRI.
Would you like to
TVS and
MRI?
will tell us the depth of invasion of the
TVS and MRI can be of help in diagnosing placenta previa syndrome.
But is MRI needed in all cases?
No,
not in all cases.
I think
this is something which I would like to state. Although textbook says MRI, but believe me, all accretas can be diagnosed with your color Doppler. You can see the color Doppler, you see the invasion into the myometrium, and you see the distance between the bladder and the myometrium if it is on the anterior side. So you can understand the invasion into the myometrium. Very well, you can understand it's an accreta syndrome and be prepared.
Yes,
MRI is posterior placenta. When the placenta is posterior, it is more useful. MRI.
Yes. So MRI is
there
used
you can go wrong with the
difficult
ultrasound.
diagnosis.
Yes, absolutely. Dr. Leela is correct. In a posterior accreta, there you can have a better, there MRI can pick up much better. Anterior, you do not need an MRI at all.
Exactly.
Your bladder forms, your bladder gives a very good delineation of the accreta. Yeah. Placenta.
It's a good window, and we can diagnose very easily by a good ultrasound with Doppler facilities.
Yes. So the message is that ultrasound with color Doppler is enough for the diagnosis of placenta accreta spectrum. MRI is only used where there is a diagnostic dilemma, like posterior placenta previa, or to assess the depth of invasion in suspected parcreta cases. So now, Dr. Anu, how do we plan for cesarean section? Dr. Anu, are you there?
Yes, ma'am.
Yeah, so now this patient is already 36 weeks gestation, 2 previous cesarean section and placenta accreta diagnosed. So now we have to plan for a cesarean section. So what are the pre-operative preparation for this patient you would like to go?
पहले ये बताओ कि करोगे कहाँ पे मैं CS
already
कहाँ
higher center पे आ गई है patient has already referred the case to us.
सबसे इम्पोर्टेंट है काउंसलिंग की कुछ भी करना पड़ सकता है सबसे
patient and relatives are counseled for the post-operative or intraoperative complication and need for blood, and there is possibility of hysterectomy, and we should give prednisone as the pregnancy is less than 37 weeks. We arrange all.
So counseling, what you are saying is counseling, and
Yes,
then steroid cover.
Yeah.
Yes. Any other steps? Anybody would like to add?
She is a case, madam, she is a case of GDM, so we have to be very careful about steroids. She is a case of thalassemia.
Yeah.
Yes.
I don't think it's
so have to be, yes, and she's a case of GDM.
Okay, so glycemia should be aimed for.
Thalassemia, and she's 7.5 gram hemoglobin. So we have to ask the patient to arrange blood beforehand. There is no question of if she has to arrange blood. Since I'm not sure whether it has invaded up to the bladder, so we would like to involve the surgeon as well, because it might have involved the bladder. Third thing is that
there is 1 centimeter gap between the bladder. There's a gap in the bladder and the placental invasion.
I could not make out with that figure. I'm sorry.
But
I would like to involve the surgeon anyway.
Okay, you would like to have a urologist standby in case of need.
Try to avoid the placenta.
Again, a urologist, very good enough, but surgeon at least. I might like to, I don't know the extent of bladder invasion, so we might like to catheterize the ureter, but that is just another thing I would like to do is that I will always counsel for, we have to go for hysterectomy in this case. She's already third para 3, previous 2 cesarean. We have to go for hysterectomy in this.
Yeah.
I don't think it's always necessary, but we have to consult that it may be needed. Hysterectomy is not done in every case, because many times
it's not done in every case.
uterine artery ligation can be done even before starting incision into the uterus.
So optimizing the timing of delivery.
Sorry, ma'am, there's something known as triple pre-procedure as well. So before cesarean, we will do the tamponing of the uterine artery so that we reduce the blood in the
Yes,
uterus.
blood loss.
And then we can also go for a removal of the myometrium, and then we will close the defect. So in those cases, the recovery is better, and we can also do it for many that want to conserve the uterus. While in case of when we have left the tissue inside and we have started the patient on methotrexate, and we have monitored how it has how the placental resorption has gone, we have seen that the post-op period of and post-op recovery of patient who has undergone triple P procedure is better than those who have
gold standard for pass.
Accepted treatment is obstetric hysterectomy. Conservative measures are only done in setups where patient is not willing
Not
for
ready
hysterectomy,
for
consent has not been taken, or maybe the placenta is separated, some part of it is left behind. So these are only cases which is done on certain cases as per need. But let us talk about the standard treatment.
So okay, first of all, let's divide it into pre-operative and per-operative. My question was pre-operative preparation.
Yeah. So it has been answered, but just to summarize, so we have to have a best balance between fetal maturity and the risk of unscheduled delivery, that patient going into labor in the middle of the night. So that balance has to be maintained. And a multidisciplinary team should be available at the center. A senior obstetrician, pre-operative anesthesia clearance, neonatologist, blood bank, urologist, and critical care team, all in coherence should be there to treat a patient. Because when we are proceeding for hysterectomy, the baby should get the best treatment. So neonatology unit is very important. And post-operative care, again, will be taken care by the critical care team. So a bed ensured in critical care unit is also equally important. So steroid cover, as we have discussed, correction of anemia, blood and blood products should be available, pre-operative counseling and consent about the risks, the need for hysterectomy, blood transfusion, urinary tract damage, and then later she will not have menstruation. The effects of hysterectomy should be explained in a clear language with also local availability of level 2 critical care bed. So now coming to the operative steps.
Just one question more I would like to ask. I think most of the panelists here are doing their own ultrasounds. Would you like to do a repeat? Would you personally like to do an ultrasound in this case before taking her up for surgery?
Sure, ma'am.
Just before taking her to OT.
Definitely.
And what would you like to see?
The distance
see the myometrium thickness.
One.
To know the
Second.
extension of placenta, upper edge of the placenta.
Perfect. 2. Second. Third. Anything else? You would also like to see placenta, yes. Fetus, you see tooth. You would also like to see the fetus. Like maybe the fetus may not be in cephalic line. So wouldn't you like to see which side is the head and which side are the legs and of the fetus also, if you're trying to do if you're doing your own ultrasound? So one, you see the placenta, you also see the baby before you're doing your own ultrasound. Right.
Yeah. So anesthesia, again, choice of anesthesia depends on the anesthetist available, whether it's a GA or epidural combined. Cesarean hysterectomy with placenta left in situ after delivery. And in these cases, the ideal is total hysterectomy. Because if we do subtotal hysterectomy, the patient might bleed from the placental bed, and the source of bleeding is left behind. So we ended up doing a hysterectomy and the patient is still bleeding. So close monitoring of volume status, urine output, and ongoing blood loss is equally important with critical care services available post-operatively. Now, Dr. Varsha Sinha, can we predict, like in this case, this patient was referred from a single doctor institute, or single nurse, and the doctor who runs in a single nursing home, operates in a single nursing home unit, to a peripheral, to a apex center. So can this placenta acreta be diagnosed earlier as in this case, and referred at the right time? I'm talking about antenatal diagnosis.
Yes, ma'am. We can do the ultrasound at 32 weeks, and we can see where the placenta lies. If it is placenta previa associated with previous to cesarean, we need to suspect the accreta spectrum as well, that it might, because of the poor decentralization, it might have entered the trophoblastic differentiation might not be proper, and it might have entered the myometrium. So we need to do a scan at 32 weeks and see if the placenta is low-lying and anterior. That will obviously increase our suspicion that it might go into the accreta spectrum.
It can also be diagnosed during early weeks of pregnancy. When blastocyst is seen in the scar, then it may convert into placenta accreta later.
Yeah, suppose we ended up opening suppose in a rural setup, we have opened a cesarean section without any ultrasound, and then we find placenta accreta. Then what has to be done? Now, suppose I am in a peripheral unit with I don't have any helping hand, and I do not have facilities of blood transfusion, and now I ended up opening an abdomen with placenta accreta. So what
has to do hysterectomy?
You can send the patient.
I've not delivered the baby. I've not delivered the baby. I've just opened the abdomen.
Send the patient to better
I've opened the peritoneum and I've seen.
Naked eye inspection of uterus can also tell it is placenta.
Yes.
We
At
can
the surface of
the upper segment.
there is a placental bulge. There is increased vascularization. There is
increased vascularity.
So we have diagnosed placenta accreta because we are seeing.
If they don't have facility, then send the patient to better center. Just close and send.
In that case, the
So
baby
not
has to be delivered.
exactly. So when we do not have the expertise, or the facility or the helping hand to treat such patients, it is better close the abdomen and refer the patient to a higher center with appropriate necessary arrangements so that she's taken up in the center if she's not bleeding. If we have the facilities, we wait till the assistant comes, blood is arranged, and pediatrician is available with all arrangements. We can always wait, and when all the necessary arrangements have been done, we go ahead with the delivery of the baby. So what are the tips and tricks anybody would like to share? Dr. Sunita Murmu, what are the tips and tricks of delivering the baby and going ahead with obstetric hysterectomy?
In case of placenta previa, if it is anterior placenta previa.
Placenta accreta, I'm talking about placenta accreta.
Okay.
So it is a diagnosed case of placenta accreta. We have to deliver the baby and do a hysterectomy. That thing has been set. So what are the steps we do? What are the tips and tricks?
So after the baby is delivered, it is better you don't.
No, she's talking off before the uterine incision.
Where do we put the incision?
Yeah,
start from uterine incision.
Uterine, first of all, once the abdomen is opened,
skin incision, choice of skin incision, choice of uterine incision.
So skin incision, it is always better to put a vertical incision if it is a case of placenta accreta, so that if needed, you can extend the incision above also. So, and once the abdomen is opened, if it is a case of placenta accreta, and you can see the bulge of placenta anterior on the anterior wall of the uterus in lower segment, it's better to deliver the baby by putting an incision on the uterus little above from the lower segment to avoid cutting the placenta. And then you deliver the baby. And if you have planned to proceed for hysterectomy directly, then it's better not to try to separate the placenta and then proceed directly for the hysterectomy.
But should close the incision.
Yes, madam. Any other tips and tricks? Please come forward. Whoever would like to share.
Ma'am, there was something I was reading, and it wrote that even fundal we can see like in a classical cesarean, but it has written that even posterior uterine wall incision can also be made. Although I've never come across any such case where posterior.
It may be difficult to deliver the baby through the posterior incision. Yes, posterior you can in the upper segment.
Yeah.
So anybody would like to come in with the panelists? Anybody would like to come in?
Mostly once we have tried, we did uterine artery ligation beforehand. Then we did incision, give incision, and then took out the baby, and thereafter as much as placenta could be removed, we removed, and only a small amount was left. And we discussed everything that be ready for hysterectomy also. This was done, I think, 1 week back, and patient went back also. But hysterectomy was not needed in that case, and patient did well. So one thing that we can do, uterine artery ligation before giving incision into the uterus. That will at least minimize blood loss.
No,
And
uterine artery ligation after delivering the baby.
No, just we did earlier. Just we incise the intravesical pouch. Listen, we open intravesical pouch. Just bladder was pushed down, and then we did uterine artery ligation, and thereafter we gave incision. This we have tried, and it was successful, and patient went home also. So I think, I don't know what is advocacy, but we have done, and I have studied it somewhere also that it worked, and many times.
No. The uterine artery, they say कि baby out.
Mostly हम लोग ligation बाद में करेंगे, baby out होने के बाद.
Baby out हो जाएगा, baby out हो जाने के बाद.
You 100% करना है, उसमें 100% करना है.
आप placenta out मत करिए. Baby out होने के बाद cord clamp करके you deliver the uterus, exteriorize the uterus. You push down the bladder, do the uterine artery devascularization, do the ovarian artery devascularization at the level of the uterus, and you wait. If the placenta in that meantime,
था ना, उसमें vessels इतने दिख रहे थे कि लग रहा था पहले उसको हम बांध ही लें, और बांध के just I did, and this is only 1 week back, and patient went home, and placenta was, some amount of placenta was left behind because it could not be removed, and there was no need of hysterectomy in that case. This was also a case of previous 2 cesarean, but it may be partial creta, it was not fully per creta.
Yeah, maybe the diagnosis was not proper, was not correct. So choice of skin incision, as discussed, can be a vertical incision. It can be also a transverse incision, a broad muscle cutting transverse incision can also be done. And choice of uterine incision, it should be higher than the level of placenta. The uterine incision, our aim should be not to deliver the baby by cutting through the myometrium without disturbing the placenta. And placenta should not be touched or try to remove manually at all times. So after delivery of the baby, if we should not be motivated to remove the placenta or try removing placenta. And as planned, if the diagnosis is correct, go ahead with hysterectomy. Before delivering the baby, we can go for bladder dissection so that the bladder is pushed down well, and the steps of hysterectomy can be completed in a quick manner. And we don't lose time in dissecting the bladder if it is done prior to baby out.
Is it necessary to close the uterus before going in for hysterectomy?
I don't think so. Why do you waste time?
Because we'll be wasting time
if you are doing
hysterectomy. Yeah, that's what I felt.
No, there is no use, but the only thing is sometimes you have a technical difficulty, so you can oppose the uterine incisions with Alice tissue forceps, something, just oppose it, so that the technical difficulty of the hysterectomy is not there. That is all. One extra point, if you have facilities for uterine artery embolization, please place the catheters. Please place the catheters before giving the uterine, after anesthesia and before giving the skin incision, so that you can embolize as soon as the baby is out.
So shall we move to the fourth and the final case?
Yes.
So she's a gravida 3, para 0, abortion 2, admitted in active labor at 36 weeks gestation. Cephalic presentation, clear liquor, average size baby. She was a normotensive patient. Hemoglobin 9g%, bilirubin, serum bilirubin 7.3, direct bilirubin 5.96, ALT 491, AST 275, ALP 216, PT INR was 1.5, platelet 1.2 lakhs, no, serology negative, blood sugar within normal limits. So this is a case of jaundice in pregnancy, already in active labor. So what is the possible diagnosis, and what prophylactic steps should be taken now to minimize the risk of PPH? Anybody? Dr. Leena Nair, Dr. Varuna Verma.
She's having jaundice in pregnancy, and these people, they are very prone to PPH. Yes. So we should keep ourselves prepared that in case she goes in for...
Because
What do you say?
platelets are going down now. Liver enzymes are raised.
Yeah. So
So
we
what,
must
what
be
is the
prepared.
preparedness we would like
Must
to
be
do?
prepared for facing PPH after delivery, you know. And
So-
since the baby is also premature, we have to take care of the baby as well, and we have to keep the blood products ready. And here, since she's jaundiced, we may have coagulation failure, so we have to be prepared. A good blood transfusion unit should be available. If these are not available, we should try to transfer the patient to such a center where we can get adequate quantity, because they can go in for massive hemorrhage. So these patients should be shifted to a center which has all the facilities for massive blood transfusion around.
Yes, ma'am. I would like to give her injection Canadion.
Injection Menadion, that has to be given prophylactically.
Yeah, vitamin K 10 milligram can be given.
Yes.
Before going for cesarean or anything. So 10 milligram vitamin K can be given. And if there is clear-cut HELP syndrome, we can go for ultrasonography also. And if HELP syndrome is diagnosed, then we can go for corticosteroid also.
She's
12
normotensive.
milligram.
She is
She's
normotensive.
normotensive.
No.
She's normotensive. She's got jaundice and
Blood
pregnancy.
pressure is normal.
It's not necessary to diagnose for
maybe
a
a case
HELP
of
syndrome.
pregnancy
Every time blood
cholestasis.
pressure not increase. In every case of HELP syndrome, it's not necessary that blood pressure will be more. So many a times, even in normal blood pressure, normal everything, but if the liver enzymes increase and platelet count is a bit less, I think 1.2 or like that. Though it's not very low, but still there may be a case of just partial HELP syndrome or a minor HELP syndrome. So we can think for that also, because liver enzymes are increased, bilirubin is increased, and platelet is low. So
It may be pregnancy cholestasis.
No, in pregnancy, in obstetric cholestasis, serum bilirubin does not go up to 9.
it's not increased to so much. It's not
So
much.
this, as rightly pointed by Dr. Maushami, is a case of jaundice in pregnancy. So with jaundice in pregnancy, we all know coagulopathies is the commonest cause of. It is a fourth T, that is thrombin is going to be the cause of postpartum hemorrhage, and you have to combat the thrombin aspect of postpartum hemorrhage. So very important is that we know with any of these thrombin aspects, when you have any kind of tissue trauma, increases bleeding. So minimize tissue trauma. That so if possible, if she can have a vaginal delivery, try to minimize episiotomy. See that if episiotomies cannot be given, minimize episiotomies as well. And then you have to vitamin K. Dr. Varun has already pointed out vitamin K you have to give. And vitamin K in this case, would you give it intramuscularly or intravenously?
IM.
Madam,
IM.
Varuna?
We can give IV as well in this case. And
Yes. Actually, you should. It is the physician's advice intravenous, because with this kind of bilirubin, if she is bleeding, then she will have an intramyometrial bleed also. She'll have a muscle hematoma wherever you're giving that injection. So it is advisable to give an intravenous vitamin K in this case. You see, all physicians will give vitamin K intravenous when there is jaundice. So this is preferable in this case. Otherwise, आपके muscle avoid intramuscular injections in this case. मतलब आप intravenous injections use कीजिए इसमें जितना हो सके.
हेमाटोमा बनेगा.
Muscle hematomas बनेंगे आपके. हाँ, बन सकते हैं. Then so these are certain things which one should keep in mind. मतलब just don't think of uterus, think of the systemic things also whenever a woman has jaundice with pregnancy.
Yeah. So
What is the reason for a jaundice? Because her serology is negative. We don't know.
We do not know the reason. It can be viral
Fatty liver.
hepatitis also.
It can be fatty liver. It can be no, virology is negative. It could be fatty liver of pregnancy. It could be fatty liver of pregnancy.
It can be.
You could have.
Yeah, but blood sugar has been done. Blood sugar is normal. And so for now, since patient is in active labor, blood should be kept in hand. FFP, most important, should be given prior to delivery and in the peripartum period to correct coagulopathy. Vitamin K, as discussed, and preference for vaginal delivery, most important. This patient should be taken up for should not be taken up for cesarean section for indications like CDMR, cesarean delivery on maternal request. So, so preference should be given for vaginal delivery. Now, this patient had instrumental delivery and repair of episiotomy. She received FFP, she received vitamin K, and but after 3 hours, there is increasing pallor, pulse rate of 150, blood pressure 90/60. Uterus is well contracted with mild vaginal bleeding. Now, how do we manage this case? Dr. Anu?
First of all, what is the diagnosis? First of all, what is the
What is the
diagnosis?
diagnosis and how do we manage? What to look for? So she's already delivered.
Hematoma. There may be hematoma formation.
There may be cervical tear. There may be upper
No,
vaginal
there is no
tear.
mild vaginal
There is
bleeding.
high-
The cervical tear is ruled out.
Mild vaginal bleeding.
Hemoglobin is suddenly 4.2 gram.
There may be intra-abdominal bleeding.
Absolutely right. Perfect. Very good.
Okay, there is instrumental delivery. Okay.
She had instrumental delivery.
Yeah.
So,
If
there,
she had
so
in-
we
there
have to
can
now
be.
look. We have to look into the vagina, put a speculum, and look into the episiotomy repair. We have to look for any missed out hematomas,
Hematomas.
any cervical tears. Yes. So when we examined, we saw a large vaginal wall hematoma, which was seen opposite to the repaired tear. So since after she delivered, the whole labor room was relaxed. Jaundice patient vaginal delivery ho gaya, and then it was left to repair by a junior doctor, and the tear was missed. So this patient had evacuation with layer closure, followed by vaginal packing under anesthesia, and the patient recovered. So traumatic PPH following vaginal delivery can be due to extension of episiotomy, perineal tears, parauteral tears, or vaginal lacerations. And the hematomas can present as pain or change in vital signs disproportionate to the amount of blood loss. So large and enlarging hematomas require incision and evacuation. The involved area should be irrigated and bleeding vessels ligated, but mostly we find diffuse oozing where layered closure will help to secure hemostasis and eliminate dead space. So to wind up, PPH can happen without warning. The strategy is to stay prepared to handle hemorrhagic emergencies. Protocols and algorithms should be displayed in labor room. Regular PPH drills should be done in the labor room. Maintaining obstetric hemorrhagic carts and boxes helps. PPH warrants sure and swift obstetric judgment. Increasing experience and will to learn from each experience serves not only to sharpen one's alertness during this stage. So saving the life of the one who gives birth to a new one. Every mother counts.
There are 2 questions in the chat box. Dr. Moshmi, one question is that, I don't know for which question, Dr. Lata Agarwal has mentioned, why not try suction? So I don't know for
why
where
not? Why not?
Try suction. I don't know where it from.
In case of PPH, we do suction cannula and leave for half an hour. Many times.
Okay, maybe for the first case where PPH cesarean section was done for twins. So after medical management, balloon tamponade was done.
Yeah.
So once balloon, maybe for that case. So once medical management has been done, balloon tamponade done, patient is in shock, then again there is, I think we are wasting time. We can, instead of balloon tamponade, we could have used a cannula there.
SR cannula.
Yes. But at this stage, it is wiser to take her to the OT and open her up. Then losing time would actually be more.
But before applying uterine tamponade, we should ensure that the uterine cavity is empty as she is passing.
Actually, all the clots are removed and all the placental tissue, bits of
We
placental.
first ensure that the uterine cavity is empty. So at first we suction the uterine cavity.
So balloon tamponade has been widely, actually it has been discussed very elaborately.
Yeah. So
Dr.
that is,
Madam. Yeah.
Okay, the next question here is that in cases of the placenta accreta syndrome, what will you do if the bladder is involved?
If the bladder is involved, bladder can always be involved. In cases of placenta accreta, there will be invasion into the bladder.
To keep the urologist present.
Yes.
Ureteric stent should be placed beforehand and try to give, and urologist must be present at the time of operation.
Yes.
To tackle any injury.
Practically, we can keep the surgeon, especially urologist, if possible. Otherwise, general surgeon also.
Yes.
Because in our part, there is no MCH urosurgery. So we call general surgeon whenever we find such case, so that at least they can take care of the bladder.
Yeah.
We will
yes,
try.
Doctor.
If we Okay, you go ahead.
So, yeah.
No, no,
So,
fine, fine,
We'll
please.
try to find a cleavage. If we can find a cleavage between bladder and uterus, and if we can coagulate, and then we can go ahead with hysterectomy, or if we can separate it, then there might not be any need of hysterectomy at all, or we have to leave the placenta behind and not try to separate if we don't find a cleavage.
Yeah.
So it is very clear. We have given a very clear take-home message. If the do not try to do manual removal of the placenta in placenta accreta syndrome. Do not even attempt it. If the placenta, if you feel the placenta is coming out, नोच के placenta नहीं निकालना है, placenta bits and pieces में नहीं निकालना है. Agar, if the placenta comes, if you feel that the placenta is coming out, it is fine. If you feel, and patient is not bleeding, placenta is not coming out, you can even leave it behind. But if you feel that she is bleeding and you need to tackle it, then you definitely need a surgeon with you if the bladder is involved. Or if you feel that it is increta, percreta आपका जा रहा है, तो आपको इन्वॉल्व करना ही पड़ेगा कहीं पे भी जा रहा है तो.
कभी मैडम हम लोग वो जानबूझ के भी यूट्रस सिस्टोस्टोमी पहले कर लेते हैं.
हाँ,
कर लेते हैं
हाँ
केसेस में.
हाँ, उससे आइडिया मिल जाएगा ना कि कितना.
Thank you. My thanks to my expert panelists, Dr. Nivedita Datta, and all my learned and involved panelists, Dr. Anju Jha Madam, Dr. Sunita Murmu, Dr. Ila Roy, Dr. Minakshi, Dr. Varsha Sinha, Dr. Kavita Banwal, Dr. Leela Nair, Dr. Varuna Verma, and Dr. Anu. We had a lovely interactive session. So thank you for participating actively and sharing your experiences. So over to Ayushi, because we are running behind in time. Over to Ayushi.
Yeah. Madam, can I say something?
Can we talk in the chat box, because we need to move to the next session?
Okay, sure.
Yeah.
Sure. Okay.
Over to Ayushi, please.
After this wonderful panel discussion, we begin with the fourth and last session of today's program. We have a video demonstration of stepwise devascularization in postpartum hemorrhage by Dr. Shashi Kabra Maheshwari ma'am. For chairing the session, we have with us Dr. Ratan Kejriwal sir and Dr. Vanita Sahai ma'am. Dr. Ratan Kejriwal sir is director at Neelam Hospital, Bokaro. Dr. Vanita Sahai ma'am is director at Sahai Clinic, consultant gynecologist, member of Food and Drug Committees 2001 to 22 POXI, member of Breast Committee 2022 to 23 POXI, speaker panelist in POXI conferences, interested in social work and received many awards for that, had many research papers in national and international journals for cancer cervix, cancer breast and thyroid dysfunction. Ma'am is faculty in MGM Medical College, Jamshedpur. Now over to the chairpersons to please invite and introduce Dr. Shashi Kabra ma'am.
Thank you so much for your kind introduction. Myself, Dr. Vanita Sahai. I'm really, first of all, I show my gratitude to the organizer who have given me the chance to chair the session of such a great person who is such a good orator, Dr. Shashi Kabra Madam. She is going to talk about the systemic devascularization of the uterus. The systemic pelvis devascularization is an effective and a uterus-conserving surgical method to control the PPH, and all the healthcare provider providing maternity care required to learn this life-saving skill to enable them to make a significant contribution, reducing the maternal death and to promote the safe motherhood. So, Madam, Dr. Shashi Kabra, Madam, she doesn't need much of introduction. She is MD, FI, COG.
I think I can start if you allow me.
Yeah, Dr. Ratan Kejriwal, if he's there, then he can do the rest. But yes, ma'am, Shashi ma'am, I think you can start.
Yeah, thank you so much, dear organizers, Dr. Sadhana Gupta, Dr. Babita Shukla, Dr. Ayushi Agarwal. Thank you so much, Dr. Vanita Sahai ma'am, for the kind introduction. And thanks to...
Sorry, madam, I couldn't go through your CV, but I'm really sorry because
madam,
of my
your
connection.
kind words are enough for me.
Thank you so much. I've met you at Calcutta, Foxy, during a breast committee panel. It was very nice breast panel consultation with you. Thank you, madam. Please continue. The time is very limited.
Thank you so much, ma'am. And my special thanks to Bhagalpur, Bokaro, Dhanbad, Jamshedpur and Ranchi societies for giving me this opportunity. So I'm sharing my screen. So is my screen visible?
Yes, it is visible, madam.
Yeah. So I always say that to remove the word nightmare of PPH from your dictionary and learn the skills and drills to become an expert. Because if we want to win PPH, we have to win and we have to become experts. So this is only one part of that only. So this is a very old diagram by Mr. B. Lynch. If you see here, this is LSCS wound, and we ligate the uterine artery at two places, proximal and distal. And when we talk about ovarian artery ligation, this is not correct because the ovarian artery is a direct branch of abdominal aorta and we never ligate it here. What we do, we ligate the anastomosis of the uterine branch of ovarian artery and ovarian branch of the uterine artery that is here in the two layers of the broad ligament. So since this is a video session, so I'm shifting to my video. This is a video on uterine artery ligation. The video is self-explanatory. Bladder pushed down, palpating the pulse of the uterine artery. I take number 1 or number 10 Vicryl or number 1 catgut for the ligation of the uterine artery. Round body needle. Take 2 centimeters of myometrium, 2 centimeters below the uterine incision. Pass the needle from anterior to posterior. Chunk of myometrium is taken in this. It provides a stability to the ligature also. Then fan out the broad ligament. Take out the needle through the avascular area from posterior to anterior. Because if we puncture a vessel, then it may lead to hematoma formation here. Now look at the knot. I give 2 turns in the first knot. Make the knot square and place it nicely. Give 3 knots each in reverse direction to make it complete surgical knot. Even catgut works very well. So distal ligation is 2 to 3 centimeters below the proximal one. The technique is same. First, the needle is going from anterior to posterior, taking a chunk of myometrium. We make the uterus stand upright. Fan out the broad ligament. Look through the window of the avascular part in the broad ligament. Take the needle from posterior to anterior, not puncturing, taking care not to puncture any vessel. And then ligate it in a similar way. And you should do it bilaterally. So moving to next video. This is anastomosis of the uterine and ovarian artery ligation, and my friend Dr. Soma had shared this with me. Let's look at this. You see, here the myometrium is being punctured. Never here, remember it will cause a lot of bleeding. So here the myometrium is punctured. We take 2 centimeters of the myometrium. After holding the fallopian tube with the Babcock's forceps, same suture material I use. You can use number 10 also, because the needle thickness is little less and there will be less prick bleeding. Fan out the broad ligament, pass it from posterior to anterior, and in between the two bites, the anastomosis of uterine branch of ovarian artery and ovarian branch of uterine artery lies. So it's beautiful, it is taken care of. 2 turns in the first knot, and this is how ovarian artery is ligated, always do it bilateral, because with unilateral, we will get an half-hearted effect. So the last is internal iliac artery ligation. This is the biggest vessel of our body, the abdominal aorta. It divides at the level of L4 and L5 into two common iliac arteries, and each common iliac artery subsequently divides into one external iliac artery, and it gives also a posteromedial branch, that is the internal iliac artery. The lumen of the external iliac artery is bigger than the internal iliac artery. And we talk about inverted Y. I will be talking about inverted Y in my subsequent slides. So I am not talking about this inverted Y. You see here, it makes an inverted Y. I will be talking about these two inverted Ys. That is the division of common iliac artery into external and internal iliac arteries. Now, this picture is just showing a part of this. This is the lateral side. This is the medial side of the patient. And this is the common iliac artery dividing into external iliac artery, which is continuous femoral artery below the inguinal ligament, and into internal iliac artery, which as soon as it originates, the posterior branch, which supplies the parietal part of the pelvis, and this is the anterior branch of internal iliac artery, and it is the main supply of the uterus. So we have to ligate this artery. Now, in a pool of blood, we cannot see this part. So we cannot recognize where the posterior division is. So how will I find out that distance? Usually this distance, the place of ligature and the origin of the internal iliac artery from the common iliac artery is around 3 to 4 centimeters. So you make a measurement on your thumb or anywhere, and that you place, and you will find out the place of ligature. So the mechanism of action of internal iliac artery ligation is that bilateral ligation results in 85% reduction in pulse pressure, 50% reduction of blood flow, and arterial blood flow is converted into a venous flow, and this facilitates coagulation. Bleeding is definitely reduced, life is saved. It is difficult technically initially, but it does not have a long learning curve. You can always practice it in a gynecological hysterectomy, opening the retroperitoneum and looking for the inverted Y and recognizing the ureter in the medial flap, and subsequently you can practice 2 to 3 cases with surgeons and then independently in obstetric case. So there are two approaches of opening the retroperitoneum. One is anterior. Here we open the retroperitoneum from the cut end or the peritoneum overlying the round ligament. If a hysterectomy is done, you go through the cut end, and if hysterectomy is not done, you make a nick in the round ligament peritoneum and go on dissecting towards the lateral pelvic wall. In the posterior approach, open the retroperitoneum 2 cm below and 2 cm lateral to sacral promontory. Feel the sacral promontory, go 2 cm below and lateral, lift the peritoneum and incise it around 4 to 5 cm on both the sides. Anterior approach is easier always. These are my two companions. This is right angle forceps or mixture forceps, and this is the thread I use. Usually is number 1 silk, and if silk is not available, I use Vicryl. I make a thread double, and the single thread length is around 30 centimeter, and when I make it double, making a loop on this side, length becomes 15 centimeter. So when I used to perform internal iliac artery ligation in emergencies in my own hospital, then a problem which I encountered was that every time there is a new batch of resident doctors and they do not understand what to do. When I tell them, you show me this and that, they do not understand the anatomy even. So that led me to make a model for them, and I made a model so that they can understand the anatomy. They can also understand the technique of performing internal iliac artery ligation. So since time is short, I'm just showing you a few important clips of that video of my model. This model is around 6 centimeter in depth. So it gives an appearance feeling that we are working in the depth of the abdomen. So this is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize the internal iliac artery needs to be ligated. This is right angle forceps, also called mixture forceps. It is bent at 90 degrees and it has a point, but it is not sharp.
I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement.
This is very important to find out one place for ligation, because if we do dissection along the whole length of the internal iliac artery and vein, then the chances of multiple injuries to the artery and vein will increase.
Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral to medial.
The right angle forceps is being passed from lateral to medial, and it is grazing through the posterior surface of the artery. The loop should be ready beforehand.
Gently I will come out like this. This movement is very, very gentle. Now next step is I will cut this and make 2 threads.
Now you see beautifully, we have made 2 separate threads from a single thread. In order to avoid injury,
and this is another thread.
Decrease injury
So
by
look at the technique of applying ligation.
Emphasis of right angle forceps.
I have taken hold of one ligature.
at the
I am
nose
not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is
see beautifully. 2 turns I have taken in the first knot. Go on the superior surface of the artery.
Then very gently I applied the second throw, and again very gently I applied the third throw. Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I cut this. And just
so with this model, anyone can learn the technique, actually what is being done in internal iliac artery ligation, and they are always in a better position to assist and learn.
This is common.
So this was a 26-year-old primary gravida with full-term pregnancy, booked initially in one facility. She had ANC at one Anganwadi center, and then she had labor pain, and she was rushed to 3rd hospital at night. She went into obstructed labor and taken to another hospital, and there doctors performed emergency cesarean section for 2nd stage arrest under spinal anesthesia, and note the time at 8 a.m. in the morning. And this patient had a PPH at 10:15 a.m., which was managed medically by those doctors. Then again, she had another second episode of PPH at 12:30 p.m. and this time she developed shock. So she was taken to operation theater, and under saddle block anesthesia, the obstetrician performed left lateral cervical tear repair and also posterior vaginal vault repair. And this time patient received 4 units of PRBCs, 4 units of FFP, and 2 units of platelets. By the time, that means that patient received already 10 units of blood products and blood. Then after 11 hours, when the doctor came back from her OPD, she showed that the patient was again in shock. She resuscitated and referred to me with 5th unit of PRBC on flow. So when I received the patient, her pulse was 146 per minute. BP is, as such, if we look at the BP, it is 104/60, which is normal. But when you compare it with pulse, when we talk about shock index, then it is more than 0.9. So the patient is considered in shock. So in a patient who is already in shock, and that too after 11 hours, there is no point doing any conservative methods. You have to do some radical methods. So I did not waste time in looking for vaginal exploration. I opened the abdomen directly by a longitudinal incision. Patient was straight away from casualty to taken to operation theater. And on opening the peritoneum, opening the abdomen, what I could see, there was a huge hematoma extending from the top of the fundus and reaching up to the corpus. That's why there was a vaginal vault tear. So I had to perform a hysterectomy in this case, and the uterine artery was retracted. So when the uterine artery is retracted, usually you require to do an internal iliac artery. So after I performed the hysterectomy, there was definitely, as expected, there was oozing in the pelvis, and I performed an internal iliac artery ligation. This is a real case video, and it is not an edited video. And just see, the hysterectomy has already been performed. And this is the round ligament ligature. From the round ligament, I've lifted the peritoneum. Basically, it is the anterior layer of the broad ligament, what we call retroperitoneum, and gradually taking care not to injure the underlying structure, I'm cutting the peritoneum. And the direction of my cut is towards the lateral pelvic wall, or you can say parallel to the infundibulopelvic ligament. See, I've cut around 5 to 7 centimeter. Now, as soon as I cut it, I put down all my instruments, and with the help of my 2 fingers, I'm separating the loose areolar tissue. If you look here, you see here, it's a beautiful ureter being seen in the medial flap. Ureter says that I am very good structure. I remain in the medial flap and I will never come here in your surgery part, because we have to perform the surgery on the lateral side. And this is the common iliac artery. This is the inverted Y you can recognize. I will make it more prominent in subsequent slides. And this is external iliac artery and this is internal iliac artery. This is the right side of the patient and this is the left side of the patient. So it is clear. Now I'm trying to make it more prominent because inverted Y is still not very clear. So little more dissection with fingers is required. Again, ureter. Common iliac, internal iliac, external iliac. Now you can see very well. Common iliac, internal iliac, external iliac. Ureter in the medial flap. Because unless you recognize inverted Y, you cannot proceed further. You see, still I'm using my fingers. No instrument is required. So beautifully it is being shown. Internal iliac, external iliac, common iliac. Now I'm pressing the external iliac and feeling the change in pulse in femoral. It will go. And now I'm pressing the internal iliac artery. There will be no change in the femoral pulse. So double confirmed. Now the mixture forceps is in my hand. And as I've shown in my model, I'm doing the similar type of dissection here, parallel to the vessel. These 2 vessels, internal iliac vein and artery, they are enclosed in a sheath. So you have to cut that sheath. You have to make a space between the internal iliac artery and the vein to pass the mixture forceps. So you see here, I've recognized one place, which is, as I told you, 4 centimeters below the origin of the internal iliac artery. And only there, I'm doing the dissection. I'm not doing the dissection throughout the whole length, because everywhere I will increase the chance of injuring the internal iliac vein. So only at one place I'm doing it. And the movement of my mixture forceps is parallel to the vessel. Now from lateral to medial, that side is your external iliac vein. So from lateral to medium, I'm inserting it. Remember the word lateral. The loop should always be ready beforehand. So my loop is ready here. So the insertion of the passage of the mixture forceps is lateral to medial. Remember the word lateral to medial, or any side, lateral to medial. I do both internal iliac artery ligation from the same side, right side. Anybody can choose their side, but remember the word that mixture forceps is passed from lateral to medial. Because if we pass it from medial to lateral, we will hit the external iliac vein of that side. It might get injured. So now, as I've shown in my model, I've cut the loop and we have made 2 threads. Now very gently, I'm trying to see which one is playing with which one, because I have to tie them separately. The reason behind making 2 threads from one thread is that you pass right angle forceps only once, and this will prevent injury by 50%. In one movement of mixture forceps, we make 2 threads. So now I've recognized my threads and I'm applying the knots. There are 2 turns in the first knot. I am bending my back, bowing my head in front of the superior surface of the internal iliac artery and saluting her that you are the one of the biggest vessel of the body. I salute you and I place the knot on its superior surface. I'm not pulling the artery. I have to bow my head in front of the artery. So 3 knots applied. No hurry. My brain is like an ice, not like a cucumber. So I applied the first suture. दिमाग को एकदम आइस की तरह ठंडा रखिए. So one suture is already in place. No hurry, no haste. Just remain calm. Now I am applying the second suture, which should be 0.5 to 1 centimeter away from the first one. 2 turns in the first knot. Again, I am telling, just a repetition. Then go up to the artery. Take your fingers up to the artery. Don't pull the artery. Bend your back, bow your head, and apply the second suture on the superior surface of the artery. You can see a beautiful bulge between the two ligatures. I think you can appreciate this. A beautiful bulge between the two. This white glistening area. So my ligatures are 0.5 to 1 centimeter apart. And very gently I cut it. When you cut it, you have to apply a very small traction on the thread also. So I cut my ligatures myself. I cut my suture myself because sometimes assistants pull it very badly. So now you can see beautifully. Internal iliac artery, this is two ligatures. This is external iliac artery. This is common iliac artery. Internal iliac artery, external iliac artery, and this is common iliac artery. And ureter is medial. Ureter is slipping medially. So one of the most important precautions is technique of passing right angle or mixture forces from lateral to medial. It is the correct method. And if you pass it from medial to lateral, then what will happen? That you will hit the external iliac vein of that side. So remember the word lateral to medial. So these are my own tips for you, which I have not copied from any of the textbooks. I have been performing internal iliac artery ligations in the last 22 years. And with my own experience, I've made these tips for you. First thing is that you have to open the retroperitoneum. That is basically a broad ligament anterior peritoneum. There are two methods. Anterior is open the retroperitoneum from round ligament and go parallel to the infundibulopelvic ligament, as I've shown here. And if in few cases you have to do posteriorly, then you palpate the sacral promontory, go 2 central below and 2 central lateral. And the way you lift the parietal peritoneum while opening the abdomen, you lift it with an artery forceps and make a knee, and under vision you go on cutting. Then once you cut it, you keep all the instruments aside and only do finger dissection, as I've shown. Because if any instrument is in your hand and you do finger dissection, that instrument will pierce the major vessels. Then locate the bifurcation. Unless you recognize any structure, you never do any surgery. You have to recognize the structure. So locate the inverted Y, as I've shown you in both the model and my video. Then always recognize internal iliac artery as a medial structure, which does not cause any change in femoral pulse. It is the external iliac artery which cause change in femoral pulse, because femoral artery is a continuation of external iliac artery. And you doubly confirm by pressing both the internal and external iliac artery. Then movement of the mixture forceps or right angle forceps is always from lateral to medial on both the sides. That means from the external iliac side we are coming. Then careful not tying in the cavity, no pulling, always pushing. Make yourself humble, bow your head in front of the superior surface of the artery. Then two ligatures 0.5 to 1 centimeter apart. And last but not the least, always do bilateral, because the literature says that the chances of re-laparotomy and morbidity increases if we do unilateral internal iliac artery ligation. And this I've seen in my own experience in last 22 years. So lots of thanks for giving me this opportunity. And with this, I seek your valuable vote for ICOG Governing Council membership, and I'm open to any questions.
Thank you so much, madam. It's a meticulous surgery you have shown us in a very basic manner. That was a wonderful video. We have liked it very nicely. It has helped a lot to all of us. So can you share this video to us also in this group?
Yes, ma'am. Yes, it is all for teaching.
So very beautiful to learn. Thank you so much.
Thank you.
Any question?
Ma'am, is this model, have you made it, or is it locally available for simulation?
Madam, I made this model myself, and the things which I used is one is Rice tube, one Eurobac tube, and one infant. Then I've sprayed it.
I know that I've seen you once in a workshop also.
Yeah, but anyone now the practical obstetric committee is about to endorse this, and anyone who wants the model for teaching, I can come and I can teach, and I can give one model also for further practice.
Because it's an excellent video. Madam, just we want to invite you for a critical care conference that we are going to organize on 1st and 2nd December in Bhagalpur. So please come and train our doctors as well as us. So can you come on 1st and 2nd December schedule?
Yes, ma'am, I can.
Okay, on critical care. Okay. Thank you, madam.
Actually, this is the basic thing. Unless you teach them on a model, the technique, when we tell them you give double thread, they do not want to give. So they must be trained on the model. Only then they can assess better in life cases.
That's very better. Your model was very beautiful, and you were
Actually, the biggest, I
so
don't
nicely.
even right
I
now.
have,
The
I have
biggest
done
fear-
internal iliac ligation, but with the assistance of surgeon. Surgeon
No,
always staying with me, and then I did.
with all the internal
Twice
iliac
I've done.
ligations, I think when I feel the place where I'm most scared about is that teasing of the fascia, that fascial teasing.
Madam,
that
don't
is-
worry. See, first thing is that this right angle forceps is
Absolutely,
pointed but not sharp. Okay.
Yeah.
You just, as I've shown you, go only parallel to the vessel, and only at that 1 centimeter area where you have to pass your mixture forces from lateral to medial. Only that area.
It was a very wonderful tip, ma'am.
It's a very important
Parallel
tip.
to the vessel, yes.
You don't have to do the movement along the whole this big length of the internal iliac artery. No, not like that.
That's not required. That's not
You
required.
were going, madam, you were going parallelly to the artery. Before that, the time of dissection, you were parallel to it to remove the sheath.
You have to remove the sheath. In my model, I have represented the sheath with my kitchen cling film. The sheath encasing both the internal iliac artery and vein. And when you separate the sheath, then when you pass the right angle forceps, then remember we are grazing through the posterior surface of the artery, because arterial wall is thick, the vein below is thin, so you will graze through the posterior surface of the artery.
And at the time you're pulling the loop, that's very nice, and cutting it in the two.
Your model was
don't have
wonderful,
to.
ma'am.
So no, you don't have to
do.
do.
You do a double loop. Always, if you do a double loop, that we've been doing. Always use a double loop, cut it, and just in that case, then you can slowly bring it.
We have to try it. Very gentle.
But you don't pulling two thread. That's you don't have that. You don't have to do twice.
Exactly, because even passing the right angle forceps may cause some injury. You are very careful passing it. Why not only once? Why 2 times?
Yes.
Yeah, that is the reason behind making a double loop.
That's very well.
And second thing, it is a big structure. It is the third biggest vessel of the body. So the bleeding can only be occluded by 2 ligatures.
Yeah.
And never cut it. Never ever.
Never cut.
Madam, thank you, madam. Please do come to Jharkhand.
Dr. Ratan Kejriwal, sir, to please give the concluding remarks.
Dr. Ratan Kejriwal, sir, please unmute yourself. Please अपने आप को unmute कर. Unmute yourself, sir. Sir, unmute yourself.
Not able to hear, I think.
He's not hearing.
केजरीवाल सर अपने आप को अनम्यूट कीजिए. आपका मोबाइल म्यूट पे है. आपका मोबाइल म्यूट पे है. हाँ.
अब आया. What I would like to give my message that in such an emergency where the heavy bleeding is there, and in such a situation, if you do the internal ligation, really it is a worth paying all the way. But to take the decision to have a very good teamwork, of course, very little number of the gynecologists they have the skill to ligate the internal iliac. So always we persons like we all person, I don't know about the younger gynecologist, but we always try to call a surgeon to ligate the internal iliac. And really, in a nowadays, what I see, you see that in a uterotonic drugs are very effective, and in 90 to 95, you say %, we manage the PPH by the drugs and all. Sometimes internal iliac is very effective all the way, and it's the last effort all the resort to go the internal iliac. In my life, I never got such one. But of course, in the past time, we had a lot of PPH. Nowadays, we have a very less number of PPH. So thanks to the God and the teamwork, the uterotonic drugs, and the teamwork and the multiple pregnancy are very less. That is also one thing. And antenatal checkup. So we are in a very comfort position nowadays as a gynecologist or the obstetricians. Thank you. The whole deliberation which has been given by the gynecologist. And it is a big epic all the way to manage the PPH. Time-taking decision is the most important thing. And the senior gynecologists are much more effective than the younger one. They lose the mother and child sometimes. So thank you very much. I enjoyed the whole session.
Ma'am, there is a question for you. Shashi ma'am, there's a question for you.
I read that question. The answer is that you always keep a bulldog clap ready when you perform internal iliac artery ligation. So when there is mild bleeding from the vein, you just apply a pack and keep it for a few minutes. And sometimes the bleeding will stop. And if it is not stopped, then apply the bulldog clamp. Just relax, no panic, and call your surgeon friends. And what you need is a 30 proline suture, and they will suture it nicely. So always better you keep a 30 proline suture in your routine.
Madam, thank you for the nice demonstration. You demonstrated the internal iliacs in such a way. It's very easy all the way to diagnose the internal iliac just by two methods, just pushing the or palpating the external iliac and just to see just about the ureter.
Thank you so much.
Really a very good demonstration.
It is a life-saving operation.
We enjoyed your surgery very much, and I think in future we'll come across with you in some CME live, and that will be useful to us. Thank you. Thank you very much.
Thank you.
Thank you.
Moshmi, who's going to give the vote of thanks? It was excellent.
Yeah, Dr. Ayushi will propose the vote of thanks.
So at the outset, I would express my gratitude to the societies of Bhagalpur, Bokaro, Dhanbad, Jamshedpur, and Ranchi for coming together for today's program. I would like to thank our chief guest, Dr. Rangina Sinha ma'am, for her gracious presence and words of wisdom. My sincere gratitude to Dr. A.K. Devdas sir for gracing today.
जरा मुझे बुला लेना लास्ट
Us the blessings.
हाँ मैम, vote of thanks हो रहा है.
हाँ मैं
ठीक.
Reverence to Dr. Usha Nath ma'am for being with us for words of wisdom. Next, I would like to thank the presidents and secretaries of societies, Dr. Preeti Balasahai ma'am, Dr. Mamta Rath ma'am, Dr. Suman Sinha ma'am, Dr. Roma Yadav ma'am, Dr. Ratan Kejriwal sir, Dr. Vanita Sahai ma'am for chairing the session and giving their valuable inputs. Lots of regards to our moderators for the wonderful speakers, Dr. Sadhana Gupta ma'am, the key organizer of such and many such wonderful series of program for the excellent talk. Dr. Nalini Mishra ma'am for sharing her innovations and the very practical tips with us. Dr. Shashi Kabra ma'am for sharing such intricate and wonderful videos. I extend my gratitude to the moderators, Dr. Moshmi Das Ghosh ma'am, for planning such brainstorming case situations for the panel. Thank you, Dr. Nivedita Dutta ma'am, for being with us today and sharing your expert opinions. I would like to thank our esteemed panelists, Dr. Ranju Jha ma'am, Dr. Sunita Murmu ma'am, Dr. Ila Roy ma'am, Dr. Minakshi ma'am, Dr. Varsha Sinha ma'am, Dr. Kavita Banwal ma'am, Dr. Neena Nair ma'am, Dr. Varuna Verma ma'am, and Dr. Anu ma'am for giving the valuable insights and the engaging discussion. I would thank Dr. Moshmi ma'am for all the hard work for making today's program successful, and the ITT for the excellent platform. And thank you, audience, for being with us.
Thank you, Dr. Ayushi. I call upon Dr. Sadhana Gupta madam. For
I was just writing that.
Yes, thank you. I was listening on all the wonderful, so many inputs on the internal iliac artery ligation. Shashi, I think this was the most discussed in this society. So many things on the internal iliac. And
it was a really pleasure to interact.
So a lot of issues, and Nivedita, because you all are something on the maternal and child health, Suman ji and everybody and all that thing. And the experience of Tata Hospital, like Moshmi herself has got such a good experience.
Yeah, today's panel was excellent and full of knowledge.
And everybody was so sharing that experience, which make us very wise. So it is something really gratifying thing when we organize program. We have to call so many people, and Ayushi Moshmi is doing a lot of things. But actually, when we learn and take tips from every panel and take a note of every concern, that makes us very, very wiser, and that is the way. And we all are a team, actually, all are a team in our mission for saving mothers and preventive, not only mortality, we will say preventing criticality from the postpartum hemorrhage. So technical point, non-technical point, and it was something great. And I bring at the moment I'm at Gujarat, and the one Junagadh meeting is like something in a queue because a lot of flood. Hopefully, I will be there at the Krishna Dham in some way, because I bring really greeting, and I'm very happy that I am there on the Sunday afternoon. I thought that Sunday afternoon, and it is PPH, but we have a very good attendance. And Shashi, thank you. You were there today in the Delhi physical workshop. You could take time that you were there. So thank you always for being together. Best wishes, Sumanji, Nivedita, Kavita.
You also.
All. And yes, I see everybody. Yes.
Yes, you also.
Best wishes to you, madam. Best wishes to you.
No, Sadhna ma'am is very, very down to earth, practical.
Yes,
very humble person.
Very humble and knowledgeable and easily approachable. That is the best part.
Easily approachable and मुझे लगता है हमारे जैसे हैं साधना मैडम है, तो हमारे जैसे जैसे हम लोग जैसे हैं वैसे साधना मैडम।
So just a week from now. Voting hoga just a week
from now, and this is real time that we change the real.
Yes, madam. We agree with you, madam.
ये important है मैम, आपका एक recorded message दे दीजिएगा about your vision and mission as Foxy president. वो हम लोग प्ले कर देंगे।
हाँ, हम लोग मैडम हर जगह प्ले करेंगे, हर सोसाइटी को देंगे। और मैडम इस टाइम तो चेंज होना चाहिए, और मैंने हम लोग बस भगवान से प्रार्थना करते हैं कि आप इस बार आइए बस, ताकि हम लोग भी थोड़ा अपलिफ्टेड हो, हम लोगों को भी बेहतर लगा, क्योंकि अदरवाइज हम लोग हमेशा लगता है पीछे ही है। वी आर ऑलवेज सपोज्ड टू बी वोटर्स।
साधना मैम, अनुप्रिया आपकी बहुत बड़ी फैन है, जो हमारे यहाँ की सेक्रेटरी है। देखिए
हम लोग सब साधना मैडम के बहुत बड़े फैन है। साधना मैडम का
लगेगा ना अगर आप इलेक्ट होंगे कि फ्रॉम वन ऑफ अस, आई रियली से दैट। तो अभी हमको लगता है,
और सबसे अच्छा लगा जानते हैं उनके आज के पीपीटी में सब बोकारो के स्लाइड्स थे सुबह।
रांची के भी थे, रांची के
मेरा भी था, भागलपुर का भी था, भागलपुर का भी स्लाइड था।
फॉक्सी वाला रिसेंट वाला था, युवा फॉक्सी वाला नहीं था, अभी वाला था।
भागलपुर जमशेदपुर रांची में सारे बहुत एलिट ऑब्स्टेट्रिशियंस हैं। मतलब जो पैनल था वो इतना बढ़िया था कि लग रहा है कि कितना एक्सपीरियंस है इनको।
एक्चुअली मैम
रोज का है ना, हर दिन हम लोग इस तरह ट्रेस करते हैं।
यहाँ पे बेसिक पैशन इज ऑब्स्टेट्रिक्स। आप यहाँ पे